All right, if we could all find a seat here. This is maybe one of the first times I'm like on time for an in-person event, but I was really excited to be here and welcome everybody. And my name is Dr. Bryan Heckman. I'm a professor at Meharry Medical College. This is actually, I'm about 2 years new into Nashville, but just really excited for an event like this because it really kind of highlights why I moved here from Charleston, which was a very hard decision to leave. But when I found the community spirit and the way in which the collaborations happen here in Nashville, it was really easy to actually transition and come here myself. So it's also really nice to just be in person after 2 years of some webinars and Zoom calls. I'm actually meeting some of my colleagues for the first time after like hundreds of hours of meeting together. So super excited to be here. I want to give a big shout out to Latrice and Tracy for helping coordinate and organize this event, and really excited about what is going to come out of it. And so a couple quick announcements. The restrooms, if you haven't found them, are on the left side there. And then there are also some water and some other refreshments in the conference room over to the right. And I will try to keep it to a nice, quick schedule here, and I want to pass it over to Dr. Gill Wright, who I've also had the pleasure of meeting for the first time, even though we've had some calls. So thank you very much for all you do, Dr. Wright, and I'll pass it over to you.
Good morning. I want to welcome everyone to the first Nashville Health and All Policies Summit and Collaborations for Better Health. We're pleased to have chosen for you to be here with us today. I hope that you learn, that you network, and share with others while you're here, and that years from now the city can look back on this as a milestone in the evolution of HiAP in all of Nashville. I've got two people I'd like to recognize that are with us today. I have Mr. David Frederick, who's on our Board of Health, and the Chair of the Board of Health, Tanae Franklin. So thank them for coming. Today's summit serves as an introductory and level-setting opportunity to expand the Health and All Policies initiative citywide. Locally, this work has so far resided exclusively within the metro government, but the Health and All Policies frameworks have been used for decades around the world by institutions outside of government as well as within. And we hope to see Nashville move in that direction. The core principle of Health and All Policies is to provide for thoughtful decisions across all sectors of government and private enterprises, based on one simple insight. We all make decisions every day with implications for health of our citizens and city, whether we think about it or not. We want to instill the habit of thinking about it first. We want to learn how to think about it when we do. And then we want to learn how to translate those thoughts into actions that make the health implications better. Piece of cake, right? Again, I thank you very much for being here today. I'll turn it back over to Dr. Heckman.
Thank you so much. I'm thrilled to be here with you. I'm disappointed to not be physically with all of you. When I got this invitation, I just was so excited, and I'm actually in New York right now, helping my daughter move in for her year in college, which is why I'm not able to be with you in person, but I'm just thrilled to be part of this. And I hope I add something new to your convening today. I really want to honor the expertise and experiences that you all already have doing Health and All Policies. I know that there's Health and All Policies work that's been going on in Nashville for quite a few years. All of you have deep experience doing work on social determinants of health and equity in your own communities, in your professional work. I will be sharing some of my experiences from California, and hope that this helps to enhance the day that you have. And I also want to mention that in the process of prepping for today, I got to meet two wonderful leaders from your Health Department, Latrice Samuels and Tracy Buck. And so I just want to give a huge thanks to the two of you. And they shared with me the community health needs assessment, more about the Metro Health and All Policies work, information about the Livability collaboration, the Seeds of Equity training that you all have, partnerships that you have with across government institutions and with community and with several of the historically Black colleges and universities in the area. So I really want to commend you for the work that's already happening with health and all policies. A few of this is just a snapshot of the topics I'm going to go over today. I will start with some acknowledgments. There's a story I want to tell. And then we'll talk about health and equity in all policies, as I'm now referring to this field, getting into more details then about the work that we've done in California, and then how does health and equity in all policies intersect with work on racial equity and on climate change. And then I'm hoping that we'll have time for questions and discussion. So please do make note if there are things that you want to ask about. With a limited amount of time, I'm just going to share a few examples, but I'm happy to bring more of those in the Q&A if that's useful. And I also want to start, before we get into the content of my talk, with a set of acknowledgments. And these acknowledgments are standard practice for my team, State of Equity. We are working to transform government institutions and practices, as are all of you, to be more just and more centered on the well-being of humans. And as we work to advance health equity and racial equity, we find that it's critical that we ground ourselves in by remembering and by honoring those people who are most impacted by unjust government practices and policies. And this includes those people who've been harmed in the past, those who experience harm now, and those who will continue to experience harm, unfortunately, into the future. And in order for us, both as individuals and also as organizations that we uphold, in order for us to be in fidelity to health and racial equity values and practices, we need to reconcile with our past and center the experience of Black, Indigenous, and people of color as we do this work within government. And so on my team, we're continually seeking to understand the ways in which government is responsible for creating and perpetuating harms. And it's critical so we can work to transform government to advance racial equity and ultimately well-being for all people. This is really a continuous practice. And so we're always evolving how we do this work as we learn more. So I'm going to offer two acknowledgments as I open my talk. First, I acknowledge that today I'm on stolen land on the unceded territory of the Lenape people, which is widely called New York City. And my slide up in front of you references the Nisinan people whose land I work on in Sacramento, California. And this conference, of course, is taking place on the ancestral hunting and traditional lands of the Cherokee, Shawnee, Choctaw, Chickasaw, and Creek peoples. And I honor Indigenous people past and present. And I want to particularly acknowledge those of you who are here with us at this conference today. I can't see the audience over Zoom, but if any of you with Indigenous heritage would like to rise from your seat or wave your hand so you can be seen, I invite you to do that. So acknowledgements are only one small way that we can support the visibility of our Indigenous community members, and acknowledgements are, of course, not sufficient for transformation towards solidarity, but they are a start, and I want to offer a few more things that any of us can do, and I'll be happy to send this information to the conference team so this can go out in follow-up materials. But there's a wonderful website called nativeland.ca, and you can look up the land that you are a guest or settler on at that website. You can also look up where you grew up, where you were born. It's important that we learn the stories of the people whose land we're on. And we can also ask ourselves and our institutions, how are we in relationship with American Indian nations and with the ecology around us? Our team in particular is developing relationships with Indigenous partners, and I want to offer appreciation to Shelley Covert with the Nevada City Rancheria Nisinan tribe for sharing her guidance with us, particularly around how we do these acknowledgements. And I want to do a second acknowledgement for the Movement for Black Lives. I honor and acknowledge the movement for Black Lives, which has formed in response to the sustained violence against Black communities in the US and globally. And of course, this is a huge part of health and health equity work. I acknowledge the continued struggle of Black people for their own lives and for their own liberation and for the liberation of all people everywhere. When Black people and Black lives thrive, we all do better. And I acknowledge that Black people and Black communities are not a monolith. And I celebrate and honor the humanity of Black people, Black genius, Black art, Black joy. I acknowledge that my work and our work together for health equity and racial equity builds upon centuries of Black resistance. And we stand on the shoulders of many people. And I also offer appreciation to another organization, ONG Racial Equity Collaborative, which has helped us develop this acknowledgement. So thank you for joining me in those acknowledgements. And now I want to tell a story. Some of you have probably heard some of this story before. It's often called the upstream parable. And you may recognize this picture. This is from Chattanooga. This is a river park in your state. And in this story, so I'm actually going to tell the story about a couple of people from your own organizations. And so I have an opportunity to have two characters in my story. So my two characters are going to be Latrice and Tracy. And in this story, Tracy is down by the river. It's a nice day. Maybe she's on a break from work. And she's down there and she notices that there's a child in the water struggling and drowning. And so what does she do? She throws down her bag, she takes off her shoes, and she dives into that river. And she grabs that child and she brings them to safety on the shore, of course. But no sooner does she get that child to safety than she realizes that there's another child in the river. And so she dives back into the river and rescues that second child. And then she dives in and rescues a third child. And there are more and more children coming down the river. And she's in a state of panic. She's doing everything she can. And as Tracy is doing this, Latrice comes along and says, "Oh my gosh, what's going on?" And Tracy said, "Latrice, look what's happening. These children are, I don't know what's going on. They're falling in the river. You've got to help me." And Latrice starts running away from there up the riverbank. And Tracy is like, "What are you doing? Where are you going?" And Latrice says, "I've got to find out why they're falling in the first place so we can stop it." And this is where the story usually ends. And usually what happens at this point is the story is we have a really important conversation that often comes up in public health about the tension where there's scarce resources, and do we focus more on helping people who are in dire crisis, or do we go upstream and figure out how to prevent the problems in the first place? And it's kind of presented like this as this dichotomy. And what I want to say is I think it's a false dichotomy. I think that we need to have enough resources to do both, to do all of this. And so I have written a second part of the story that I think is a really important kind of additional part of the allegory, where imagine that all of you fortunately are around and you come running out to the river, and there's a couple hundred of you. And so 100 of you are able to help Tracy, and you are helping to rescue these children and pull them out of the river. And they're doing okay. You're not losing anybody. You've got a safety net. And in the meanwhile, and so Tracy's able to take a rest actually, because she needs it at this point. And so in the meanwhile, Tracy and Latrice decide to go up together and figure out what's going on and why this problem is happening in the first place. And so there's a bunch more of you that each go up with each of them. They've got teams. One takes one side of the river, the other takes the other side of the river. And Tracy goes up on one side of the river, and she finds actually a pretty nice setup. There's a beautiful park. There's children playing. There's swim lessons happening. There's lifeguards. There's some staff around. There are all kinds of activities happening. There's parents around. Kids are having a good time. Nobody's falling in the river. Doesn't look like there's a problem. But Latrice goes up on the other side with her team, and they find a very different situation. The area is very run down. There are children playing. There's no adults around. There's no programming at the park. There's no safety rails. There's no physical infrastructure. Their parents want to be with them, but some of their parents are working 2 jobs or even 3 jobs. Some of their parents have been incarcerated and have been physically removed from the community, and there aren't swimming lessons available, and these kids are falling in and nobody is there to help them. And so this is where we kind of see these are health inequities. These are really complex, sticky problems. And yeah, and so I wanted to share the story to kind of illustrate what we're up against and where health in all policies comes in. So what is a healthy community? This has been the key question for us in all of our work. When we first launched our health in all policies work in California, we would ask this question as we met with people in transportation, in housing, in land use planning, in parks, kind of you name it. And folks were able to get that a healthy community is not just about healthcare. Healthcare is very important, but is about all of these social determinants. And to this day, we use this question, kind of my favorite 5 words, to engage folks and bring them in on our work. Here's just a snapshot of some examples of communities that are healthy, communities that are not so healthy. I love this quote from the Institute of Medicine. It is unreasonable to expect that people will change their behavior easily when so many forces in the social, cultural, and physical environment conspire against such change. And I'm sure all of us can think of examples, no matter how much privilege and resources we have, can think of examples where it has been difficult for us to do healthy behaviors because of the environments around us. I want to share this framework. It was developed by a group called the Bay Area Regional Health Inequities Initiative. And what I think is interesting about this framework around the social determinants of health is it shows this upstream, downstream piece that we just spoke about. And to the right is the downstream work that often happens in healthcare, focus on mortality and on disease and injury. And as you move from downstream up to the left, we get to risk behaviors, which is where public health has typically worked, and for many, many decades. And as we moved from the left of that to living conditions, this is where public health has been headed, especially over the last decade or so. And I imagine that many of you are working in this sphere of living conditions, land use, transportation, physical environment, economic and work environment, and those intersections with health. Now, what has been happening more in the last few years, and my focus initially with health and all policies was on living conditions. Over the last few years, we have shifted further upstream to focusing on institutional inequities and really looking at the systems behind these conditions. And more recently, moving upstream from that to really looking at issues of social inequities. How does racism play in? How does oppression along lines of gender, sexual orientation, immigration status, class, income, wealth play in? And in fact, I think if we were to revisit this framework today, we might even add another box further to the left that's about narrative, that is about our understanding and the way that our society kind of perpetuates hierarchies of people. And I posit that we in public health have a moral imperative to work as far upstream as we can. And back to the upstream parable, we need to have enough resources to work all along this continuum. This is just an example of a data tool that we have in California, and I hope that you have resources like this in Tennessee as well, but indicators and data to understand, really at the census tract level, what the social determinants of health and equity look like for communities and for populations, and what people are up against in their very localized neighborhoods. And these are sticky or wicked problems. These are problems that are really hard to solve. They're multifactorial. You can't really define them. There's no clear solution. you find a solution in one area and it may trigger harms in another area, and there's no single organization responsible. So in my state, there is no agency responsible for alleviating poverty. There's no organization responsible for addressing racism. There's no single entity responsible for, or even entity overall responsible for addressing violence. There are very specific programs and projects, but this isn't coordinated across our state, and in most local jurisdictions, we could say the same thing. So this is where health and equity in all policies enters and is so critical. Health and equity in all policies is a collaborative approach to improving the health of all people by incorporating health and equity considerations into decision-making across sectors and policy areas. And this definition comes from the Health in All Policies Guide that my team and I developed in 2013. I'll make sure that the link to that gets shared out as well. It's available online. And we define 5 key elements of health in all policies. One is that we work at the intersections of health, equity, and environmental sustainability, and in particular, issues around climate and climate change. The second is collaboration across sectors and fields. Third is benefiting multiple partners, engaging stakeholders. And if we were to update this today, I would say engaging stakeholders and centering the voices and experience of community and leadership of community. I think our thinking around that has evolved quite a bit over the last several years. And then finally, creating structural or procedural change, really changing the systems in which we're working. It's just a snapshot of, there's lots of health in all policies plans all over the country, including in Nashville. And our Health in All Policies Task Force got started in 2010 through an executive order signed by our governor. You can see Arnold Schwarzenegger on your screen. He was our governor at the time, and he did this at a conference with Bill Clinton, establishing a Health in All Policies Task Force. It called for a whole bunch of departments and agencies to come together. And on your screen, you'll see logos from state parks, transportation, health, labor and workforce, fire and forestry, food and ag, and so on. And the first thing we did was we conducted public input sessions around the state to really understand what the priorities are for communities. And then the focus has really been on consensus and co-benefits, in part because this was an unfunded mandate. A lot of these entities initially did not even want to come to the table. They showed up to our meetings because of the executive order, but we had to demonstrate to them that this was going to help them achieve their goals, achieve their missions, and ultimately be useful for their, overall for them. We ended up forming multi-agency working groups on these topic areas. These are the topics that rose up through as priorities through our public input process from community. And each of these would bring together, for example, multiple groups, like, for example, housing, siting, and air quality. There are issues where we want to put affordable housing near public transit. And this is important for greenhouse gas emissions and for transportation opportunities for folks who are low income. And that also could mean increased exposure to air pollutants. And so how do you juggle these very complex issues? And I want to share an example from our active transportation work where we pulled together a working group. I have at the top of the slide the names of the different departments involved, and we were promoting active transportation through grant making, integrating into grant making equity considerations, integrating in an expectation that transportation and land use planning or public works agencies that got these transportation dollars would meet with the local health department and make sure that they were considering local health department data on vulnerable communities as they did their work. And it was also very important that we talk about the benefits, and this goes back to those co-benefits, but we've done a lot of work in all of these policy areas to really understand and communicate. And this is a key role of public health, to be able to talk about what are the benefits of active transportation or any of these policy areas, whether it's specifically health outcomes or things like reducing infrastructure costs, reducing greenhouse gas emissions, things that may be on the priority list for some of our other organizations and entities as well. And of course, an equity lens has been critical in our work. we ask over and over again, how might this decision affect different groups? Does this decision affect everybody the same, or are there real differences? And for example, on this slide, you'll see a number of policies and practices that have been happening related to climate change. Policies like promoting electric vehicles. This has been in the news a lot around California lately. And who's going to benefit from this? Who can afford an electric vehicle? Even if there are big rebates, who has enough money to put in the capital to get that rebate? Solar. Who are the workers that are installing solar? What kind of protections are there for them? Are there unique occupational safety risks that are connected to doing solar work that need to be considered? And so all of these things are equity implications for all of these changes that we're making in our society. And I'll come to this a little bit more later, but with COVID, there have been a huge number of new policy initiatives to support healthy communities, which is great. And as those move from emergency efforts to possibly long-term policies and practices, it's critical that we have this equity lens as we unroll all of those. There's lots of ways to define health equity. I want to share a definition of health inequity. I like this one a lot from the Virginia Department of Public Health, that health inequities, people often are confused between inequities and disparities. Well, inequities are disparities, but they are disparities in health that are a result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. And so it's really key. They're systemic, which means we have an opportunity, but also an obligation as people who work within systems to change them. Avoidable, it doesn't have to be this way, and unjust. People often ask about what we mean by policy. I think this is really important. I think of in health and all policies, there's big P policy and little p policy. So big P is like legislation, ordinances, and some of us are able to work on those. Some of us are not able to work on those. But little p policy is all the other things that our institutions and government does. And for example, here's a list of institutional functions. Does your organization collect data? What kind of data? How do you collect the data? Who do you collect it from? How do you aggregate or disaggregate? Is it public? Is it accessible? Who can access it? So right there's a whole host of what I would say are policy decisions that often are being made at a staffing or managerial level inside of organizations. And there's a long list of these areas on the slide. And my point here is that all of us have some opportunity to shape policies and practices. And so this is not just for legislatures or city councils or county boards. They have an important role, but all of us working in government and in community, and anybody who touches government has a role. Health partners play a key role. So it's really important for health and equity and all policies work that there is a backbone staff team to carry this work forward. Often it's folks in public health, but not always. There are examples of other branches of government leading this work. But there's some really critical skills that come to bear: convening, facilitation, conducting research, technical systems monitoring, reporting, drafting consensus documents. You all know if you want to move a group of people forward, somebody has to be thinking about the process and carrying that forward step by step. And so this has been critical. And even if the participating entities initially are participating on a voluntary basis, it's really critical to have some dedicated staff to move this work forward. And for the last section of my talk, I want to talk about, so we've talked a lot about health. I want to bring in more about racial equity and environmental sustainability and climate change and where these pieces connect. And I'll share an example from our work related to racial equity. So in our health and all policies work, we were initially focusing really explicitly on health and health equity. And for some of you, this is something that you've known your entire lives. And for other folks, we've come to figure it out later on in life. But racism is a key driver of health inequities. And in the last decade or two, there has been an increased amount of academic work to really document these connections in the public health field. Nancy Krieger, David Williams, there are a number of researchers that have been publishing really prolifically around these connections. And as we were talking more and more about health equity within our task force, questions were coming up around racial equity and wanting to understand those connections more. Our colleagues at the Department of Public Health created this slide that I really love, where we look at racism at the top and kind of explain some of the pathways. And so to the right and left of racism, we have racism causes differential access to resources. It also causes differential living conditions. And both of those are going to have huge impacts on health inequities. But racism also causes chronic stress. And chronic stress itself has physiological impacts on people, whether it's coming from racism or a whole host of other factors that can cause chronic stress as well. And these include increased allostatic load, epigenetic changes, that can cause this to be passed on over generations. And all of these can lead to cancers, heart disease, kidney disease, increased blood pressure. Now, I am not an expert on the physiological pathways, but I would venture a guess that there are at least a handful of people in the room with you right now who are. And I hope that in the coming months, you will be able to schedule some briefings and talks to be able to hear from them and really get in depth, because there's just a very deep understanding at this point around these connections. And I think it's really important for us working in the field of health and equity in all policies to really understand. We get a lot of questions about why we're leading with race. And in fact, we want to tackle health inequities along every line. We are concerned with health inequities around lines of gender, of disability, of sexual orientation, of income. We lead with race for a number of reasons. One is that racial anxiety is on the rise, and we have found that if we don't explicitly call out and talk about race and racism, people don't talk about it. It goes unaddressed. And so we have to center this work and normalize these conversations. There are also deep and persistent differences in outcomes based on race across any measure of success. We're looking at health, income, housing, education, and so on. Specificity does matter. So there are strategies to achieve racial equity that are different from those who achieve equity in other areas. And at the same time, when we learn ways to dismantle systemic and structural institutional racism, it helps us tackle those other areas of inequities at all. So we do call for an intersectional and holistic approach, and we also do lead with talking about race and racism. And I want to just, this slide does not do justice in any way to this topic, but I want to give this is the one slide, very brief history of government and racism in our country. Historically, racism was explicit in our government policies and practices. For example, our government interned people of Japanese ancestry during World War II. We had slavery. You all could come up with many examples of this, I have no doubt. And I hope that you will, if we had a whole day for this conversation, we would spend a lot of time on this. Over time, discrimination became illegal, but discriminatory policies have still been perpetuated in implicit ways through quote unquote race neutral policies. And there are examples of this, like voting laws that end up discriminating against some groups and not others without explicitly naming those groups. The police will enforce the same law differently in two different communities. That is discriminatory. Government agencies will respond to calls from community members for broken street lights or things like that, and we'll have different response times depending on who's calling and what neighborhood the problem is in. Decisions about bus routes and where those get prioritized, for example. And then the last part of this slide is governing for racial equity. So we're in a very exciting moment right now where actually there's a movement nationally around advancing proactive policies, practices to advance racial equity in government. And I want to show this next slide. I love this slide because there's an organization called the Government Alliance on Race and Equity. Some of you may be familiar with them. And they're working with this slide I think isn't even their most current list. I think that's probably doubled from this right now, but working with, I believe that it is now a few hundred jurisdictions across the country doing racial equity work in their government institutions. And you'll be pleased to see Tennessee up here with Chattanooga and Knoxville. So if you're not familiar with their work, I hope you will get in touch and check them out. Our team in California has joined forces with the Government Alliance on Race and Equity, and GARE has primarily been focused at the city and county level. We're partnering with them to expand this work to support state governments. And we started by piloting this in California. We're now starting to build this out with other states. But I want to just give a snapshot of what we're doing in California. So we launched the Capital Collaborative on Race and Equity, or CORE, and we did this out of the Health and All Policies Task Force. So the Health and All Policies Task Force was saying we want to do more on equity, we need capacity building, we need training, and we need a deeper understanding of institutional and structural racism. And we were so excited to find out that GARE existed right at that same time and launch a cohort program where we run peer exchange learning cohorts for state government agencies. Now, I should mention that my team, State of Equity, we are a nonprofit organization that partners with government. And so we've been able to kind of bring this in as a public-private, nonprofit government partnership. And on your screen is just a list of some of the agencies and departments that have participated. Many of these came from the Health and All Policies Task Force. This is 2018 and 2019, and we had another cohort in 2020 and 2021. We have another cohort now running in 2022. I don't have a slide for them yet. They're brand new, but we're really excited about the work that these organizations are doing. And as a result of their work with us, we now have racial equity action teams within 33 state agencies and departments. There are quite a number of working groups. There are more details up on the screen, and I will share these slides out with you after, so if you want to go back and get more details, you can. This slide just is a list of institutional commitments. So a number of these entities over the time they've participated have gone public with action plans, with commitments, with statements, with descriptions of kind of the historical legacy of injustice in their policy areas and their understanding of what they need to do to address those now. It's really been quite profound and exciting, and this is happening all over the country. So I'm going to loop back to the Health and All Policies Task Force now. And I want to share that the task force has actually done a bit of a reboot. So at the start of the pandemic, the task force started doing public input workshops again to revisit where its priorities should be. It had been a decade at that point since its founding. Held key informant interviews, did a statewide survey, listening sessions, a drive for membership among state entities to kind of re-up commitments. And in the course of that, what they heard was, yes, there was an interest in those same policy areas that we talked about before: transportation, housing, education, and so on. But there was a particular focus and interest in equity, health equity, and racial equity, and addressing the structural barriers to equity in government. And so the task force has now rebooted with a new set of 4 goals that are up on your screen that are really about internal systems and processes. So addressing burdensome program guidelines, protocols, budgets, contract and funding equity, equitable access to information and data, and then building capacity and racial equity competencies in government. And so now the task force just this year has launched new work related to grant programs, contracts, and funding equity, another related to data. And you'll see on your slide, each of these has a champion that is not from a health agency or department, but is from the entity that can have the most opportunity for influence in that area, and then participation from a wide range of departments and agencies. And we also have a couple of round tables around building capacity and competencies, and also around safe and equitable communities, and getting back to that issue around violence prevention and community safety as a key component of healthy, equitable communities. And I can't give this talk without also touching on climate change. Climate change is the single biggest threat facing humanity. This is what the World Health Organization says. The slide just quotes from, pretty much every major medical organization is talking about climate change, talking about the scientific evidence and the connections to health, vector-borne disease, air pollution, seasonal allergies, storm-related injuries, Zika, West Nile virus. And the climate crisis is disproportionately impacting the health of communities that have already been historically marginalized and harmed, and is just adding to the cumulative impacts on those communities. So the main point here is this is a public health issue, this is our issue, and it touches on everything that we do. For this slide, I just pulled in some headlines about Tennessee, what's happening in Tennessee related to climate change, flood, heat, climate hazards, infectious disease, extreme weather, warming. Extreme rainfall in Tennessee is revealing a hidden health threat, hazardous chemical facilities. There are all of these things that some people probably were thinking about this for decades, but for many of us, there are a lot of surprises coming up around how far the reach is of climate change and the impacts on health and the risks. This slide is in California, but I think that this is happening nationwide. All of these logos are health organizations that have signed on to a call to action on climate, health, and equity. And so we're seeing this more and more across both the public health and the healthcare and medical fields. And of course, there are some deep connections between COVID-19 and climate change. We're finding that there are higher coronavirus death rates in areas where there's higher air pollution, for example. And there are key lessons from from climate change work on how to address COVID, and from the COVID work on how to address climate change. And some of these commonalities are that we are all only as safe and healthy as our neighbor. This is true for both climate and the pandemic. Structural change and government planning are essential. Public health infrastructure is critical. Prevention, investing resources up front saves lives, prevents suffering, saves money. And when these threats are widely understood, there really is no shortage of money that can be found. And so we have to make it all the more clear about these threats. And of course, neighbor to neighbor support, mutual aid, these are things that are happening in so many communities. This is, you'll get this in the slides that we send out, but this is a beautiful piece of artwork made from a meeting that some of our colleagues held that kind of illustrates some of these connections between coronavirus and the climate crisis and the opportunities to mobilize health around common solutions. So another one of my favorite quotes from Anne Frank, that how wonderful it is that nobody need wait a single moment before beginning to improve the world. And I say this, and yet I know that none of you have waited a single moment. You are all here because you are already doing this work. You are deep in it, and it is just feels very good to be in solidarity and community with all of you. And I also always, in my talks with this question, what will you do? And I, again, know that you're already doing so much, but I encourage you to really think from the lens of health and equity in all policies, and especially the intersectoral piece. Are there other policy fields that you're curious about? Do you work in public health, but you don't really know people in the housing department? Do you work in um, parks, and it would be great for you to connect with somebody in transportation? What kinds of coffee date opportunities can you have to just find out from somebody else that works in your um, jurisdiction? What are your challenges? What are you trying to achieve? One of the biggest lessons that I learned in this work is I came in initially thinking, oh, well, I'm in public health, but these people in other fields, they don't know about health, or they're not concerned about population. And that was just completely untrue. And as I built deeper relationships with folks in transportation and housing and land use planning, I found just incredible people, true public servants, really there to make a difference. And it was so clear that not only were they critical to our success in health, but we were also critical to their success. And there were a lot of ways that we were able to support them to achieve their goals. So I hope everybody leaves today with some next steps and ideas about what you will do, even if it's just, I'm going to call up one person that you met today at this conference. This slide is just a snapshot of our Health and All Policies guide. It's 9 years old, but it's actually still pretty current. So I'll be glad to share that out. And my contact information, please feel free to be in touch with me. We're developing a new website for State of Equity. I'll actually be proofreading the text later today, so it's not up yet, but a lot of our materials are on our government colleagues website, and my email address is jcaplan@phi.org. So I'm gonna wrap up here, and we'll be very happy to field questions. And I think that somebody in the room with all of you is going to help facilitate this piece. Thank you so much.
Hi, Julia. Can you hear me?
I can.
Hi, my name is Elise Cruz. I work with the public health department here, and I'm actually involved in our cross-sectoral HiAP efforts. But one of my questions, kind of moving outside of, or moving from what you just mentioned, was around centering community partnerships and community engagement. I think there is a spectrum of what community engagement can look like. It can be involved, it can be community led. And so, and recognizing that often, one singular method of engaging community may not be sufficient in order to meet the needs and get the voices of those that have been most marginalized and historically impacted. And so I was curious if you could maybe talk through some of the efforts to ensure that community voices are centered in some of the HiAP work that y'all have done as an example, or some guideposts for us.
I would be happy to. And I want to start by saying that this is an area that I am really on a learning trajectory around. So I will share some of what I've been learning, and I would then guess that there are other people in your room that have deeper experience in community partnership than I do. When our Health and All Policies work first started in 2010, our community engagement was a pretty light touch. We did those public input workshops. They were critical for our work, and our priorities really were shaped by that public input. But then we really focused internally within government. And it was really important, and this was an area of tension for us. It was important to have places where government folks, bureaucrats, could meet with each other in private and have confidential conversations, because they were kind of unveiling problem areas where if they were talking in public, they probably never would have had those conversations or felt safe enough to talk about the problems that they were facing, or the limitations, or kind of the things that they couldn't figure out. However, there were not a lot of ways for the public and for community to really participate. One thing that was really important from the beginning is our Health and All Policies Task Force. I didn't talk about this earlier, but part of the structure is that it is underneath a body called the Strategic Growth Council. And the Strategic Growth Council is a cabinet level body that holds public meetings every other month. And so part of what I did is I made sure that we got time on the agenda every time that public meeting happened so that we could speak publicly about what was happening and the public would have an opportunity to show up, kind of monitor what was happening and weigh in. Now, still, that is a very light touch of community. I wouldn't even call it really engagement. It's like a very small step in the direction of transparency. As we started doing our work on racial equity within Health and All Policies, one of the big focus areas of that racial equity work has been looking at the ways that government shuts out community and really looking at transforming government practices around moving from government involved or government participation, community involved or community participation to really community centered and community led. And so I and my team have been learning alongside our government partners over the last few years. And we've been watching and supporting a number of state entities to really make changes. One of the changes that some of them have been figuring out, and this gets to those procedural and structural issues. This is a long answer, but I have a lot to say about this. One of the barriers is government is kind of notorious for asking community to show up, give input, weigh in, take time off work or whatever you're doing, help us, and we don't pay community for their time and their expertise. Well, it's really hard to pay community often because of our funding streams, there are limitations, our budget processes, we're not allowed to give out gift cards. There are all these limits. We can't contract with community-based organizations because we have rules in our government, and you may in yours as well, that if we contract with an organization, they have to do the work first before we pay them. We will reimburse them after they do the work. Well, a very small community-based organization can't afford that, and so they can't even compete. And so they're shut out. And so now we're taking steps to transform government processes to set it up so that when they're small CBOs, we can front end and give those organizations the funding they need at the start so that they can participate. We're trying to streamline these processes for selecting community partners so that they can incorporate this into their small nonprofit budgets. We're looking for ways to provide stipends and compensation to community members to participate in government processes, really honoring and valuing their time. We're requiring now more and more that when there are major projects in local communities, development projects, for example, housing development, parks, transportation, that there's a truly robust and meaningful community process. So there are a lot of changes that are happening. And in fact, with our Health and All Policies Task Force, I mentioned that we have a new roundtable around community safety and violence prevention. We've been able to now secure grant funding so that we can provide funds to a community-based partner organization that does work with youth who are coming out of incarceration, system impacted young people who are going to be helping us design and facilitate these roundtable sessions with government. So we've been taking some big steps in this department, in this area, in this direction, and it's there's a long way to go. And I think that's probably the case everywhere.
Yeah, thank you so much. I appreciate you highlighting some of those like structural and infrastructure pieces and tensions that exist and sharing some examples.
Absolutely.
Yes, I just had a follow-up and want to thank you for the empowering talk and thinking about how we can all kind of make change at all these different levels. I think that's really important to keep echoing because we can all do that together. And I did want to mention one thing that always was on my mind is like timelines. And so you showed some of the timeline from historically how things have gone. And then you talked about trying to streamline processes. But I'm thinking about how this kind of can move forward. Can you maybe share expectations for how change can happen, and given how urgent and how important this all is, kind of just how we can try to help expedite that process, and how we can also just, frame it in our own minds for what's possible and how fast.
Sure. And I didn't catch, would you mind just saying your name and
Oh,
organization?
sorry. My name's Bryan Heckman. I'm a associate professor at Meharry Medical College.
Oh, it's Bryan. Okay, great. I can't,
You're good.
my view is a little obscured, so fantastic, great. That's a great question, and I have a couple of thoughts in response. So one is we have adopted a framework from the Government Alliance on Race and Equity, which is normalize, organize, operationalize, and visualize. Actually, I think now they put the V at the front. Visualize, normalize, organize, operationalize. And as I've learned more about this framework, I've realized that we've actually been using it the whole time we've done health and all policies. And visualize means we have to have the big picture vision. We have to have in mind, like, what is the ideal? What are we really trying to get to? Even if it feels pie in the sky, what do we ultimately want? Even if it feels like a total dream, we have to go there in our minds. We have to go there with each other, and we have to hold it out. Then we need to normalize. Normalizing is having these conversations, getting together, talking, putting these conversations on agendas, talking about climate change, talking about race, talking about health equity, talking about transformation that might be uncomfortable, but really normalizing, giving people a language and an understanding. Organizing is creating the structures. So creating a task force, creating a working group, creating an annual convening. I mean, you have this annual convening. So operational organizing is creating those structures, and hopefully those structures are durable and are going to last through administration changes. You could get a new mayor, a different city council, different department head, but these are kind of durable structures. And then operationalize is when we actually change the policies and practices. And this isn't sequential. These are all kind of happening at the same time. And as we do more and more of the organizing, operationalizing piece, then we're able to expand our vision. We're able to normalize kind of bigger picture. We're able to think differently. And so it really is an iterative process. So I wanted to say that kind of conceptually. And then the other piece is, we're, a lot of these things are urgent and we need changes now. And we have to be building the building blocks. And so it can be very tempting to spend a lot of time focused on one particular project or one particular program, but actually we need to be transforming the systems. And so that I call this institutionalization. But again, this is things about, getting these durable structures in place, changing our budgets, which one pathway towards changing budgets is changing mission statements. When you change a mission statement for an organization, then that gets incorporated into the next strategic plan update. The strategic plan influences the budget. And so it is getting into these kind of nitty-gritty pieces of our bureaucracy, but they really are so critical. So I think all of that, and then I do think, we have to do the low-hanging fruit, look for the wins that are possible and celebrate them, be super public about them. I think the more that we talk publicly about this work, including our shortcomings, it can be very useful to showcase what we're doing and showcase our gaps. And it doesn't mean that we have to be blamed for them. We can say, here's other things we'd like to do. We don't have the resources. The more we're public about that, the more advocates and community members can pick that up and push for those resources for us. And so I found that sometimes there's a culture in government of, not wanting to show our shortcomings, but actually I found that that's been one of our most successful strategies, is really being transparent about those and then asking for help. So I hope that gets to some of what you're asking. It's tough. And I also wanted to note, you have an incredible lineup of speakers today, and I don't know all of the folks who are going to be speaking, but I do know I actually had a call prior to this conference with Jimmy Dills and with John Vick. And, I know Jimmy's going to be talking about decision support tools. It's a direct connection to what I've just talked about of how do you take these values and these hopes and translate that into decisions that you're making every day in your work. And then, John Vick, I think, is also part of our broader national network of health and all policies practitioners, and I think also can speak to that work and what's happening, how that work has played out in Nashville. So I'm excited for what the conversations are going to be for the rest of your day.
Hello, I also have a question. I also want to say thank you for your presentation. My name is Jacqueline, and I'm at an organization called Health Leads. My question is really thinking about the community engagement aspect. I think, we know that collaboration is necessary when it comes to health and all policies. And I think, we get that community members should be involved, but once we've invited those folks to the table, then what? Besides input, I'm wondering, what are some of the other assets or values, some of the richness that community members or community-based organizations can provide in the health and all policies approach, and how may you all have, how have community members showed up in the work that you've done in California as well?
Mm-hmm. Yeah, thank you, Jacqueline. So I guess a few things. I have been at a number of government meetings where historically those meetings have been just government folks, and recently those meetings have been bringing in community members. And one of the things that we've been doing, and I've been seeing colleagues do, is have spotlight opportunities at the start of those meetings where community members share personal experiences, share lived experiences of the issues that folks within government are working on. And so I was recently at a task force around early childhood development, and they have standardized before they have these 3-hour meetings every month or two. And at the start of it, they take about 15 minutes to hear from 2 community members, sharing their stories. And even if, whether or not they may be speaking to the specific policy issue, they may not, but they're bringing in their lived experience, and that is educational and informative for the people who have decision-making roles. It's critical. It's also really important to understand from community members what they're up against, what their priorities are. We often find that the priorities of community are very different from what folks in government think. So folks in government may have one idea, but without the lived experiences, we're going to fall short. And it doesn't necessarily mean that what we think is wrong, but it may mean that we're missing some critical pieces. So I may be really concerned about climate change and transportation, but when I go out into community, I may find that my community members are really worried about how unsafe they feel on the street, just in their neighborhood, or maybe really afraid of policing in their neighborhood and may not feel like it's safe. So they may say, well, it's great that you want me to go out and walk more, but like I'm scared to leave my apartment. And are we thinking about that when we're doing our work on climate and transportation? And so the more that our eyes can be open to kind of the holistic experiences of people, the better. And then I think that there are, community members who can have a very deep role in policy as well. And I want to acknowledge that, sometimes we're dealing with policy issues where it's very nuanced. We're dealing with very deep specifics. You have to have studied a lot and been involved for many years to really understand what these policy levers are that we're working on. And that can be used as an excuse to shut community out and say, well, they're not going to understand, so we can't slow down to bring folks in. But this is where it can be really advantageous to have funds to bring in cohorts of folks from community and provide stipends and, engage people on a long-term basis, not just one-time input sessions, but can we bring in community to be partners on an ongoing basis, perhaps over the course of many years. And so I think that's something that I'm starting to see more of is those kinds of practices as well, kind of blurring the lines a little bit more between community and government. And then one more piece I need to say is we should be hiring from our communities. And so if our civil servants don't look like the communities that we serve, that's a problem. And what are the barriers to entry? And so there's a whole piece of workforce equity that comes into this too. Are we valuing lived experience when we are hiring people? Are we requiring people to have a certain level of educational attainment that is a barrier to our community members and actually preventing us from hiring people who really understand what the needs are? And how can we change those practices so that we can have that lived experience and community wisdom on our staff and inside of our institutions?
Yeah, certainly. Thank you. And if it's okay, I'd like to double dip and just ask another question. Okay. So my other question is thinking about that funding piece. I think we oftentimes think about, when it comes to how to fund something that's about collaboration in the health world, we think about grants. Are there any examples that you might share where folks have really thought out of the box and thought, how can we maybe fund this in a different way? Maybe business approaches or other approaches to kind of getting the health and all policies approach off the ground?
Well, let's see. So initially, as you were asking the question, I was thinking about how to get funding to community. And I would say this is an area that I'm still learning, but I think that's primarily through grants and contracts. However, one of the examples that I shared is that my team, we're a nonprofit organization, we get philanthropic funding. And most recently, we designated some of our philanthropic funding to go to a community partner to support their engagement with us and with government. And so that's been really key. And I think philanthropy is a key partner. I hope there's some philanthropy folks in the room with you today. And we never would have gotten our health and all policies work off the ground without philanthropy. So our work, health and all policies, was started as an unfunded mandate. We came in as a nonprofit team. We were invited by government to step in and help launch this work. And we had philanthropy willing to kind of pay our salaries and get this work off the ground. And the goal initially from philanthropy was, we will fund this initially for a couple of years, but then we want state government to take over. Like, we're going to prove the concept. Once we reach proof of concept and demonstrate that this is a good idea and is helping government needs to step in and build this into its budget. Turns out that took a lot longer than we had initially anticipated. And it was about 8 years until, we had failed attempts at getting health and all policies built into legislation and built into the state budget. It took us 8 years before we got this work built into the state budget. And now there are 3 full-time positions inside of state government at the Strategic Growth Council. But what we also found is, as our work grew, we needed more and more resources. And there was a special role for philanthropy that just could not be filled by state funding. So state funds, and I'm saying state, but I need to remind myself, most of you are working at a local level, but government stepping up and to continually push the envelope in terms of the narrative, and normalizing concepts, our focus on health equity, racial equity, climate, some of these pieces where it might have been hard for people inside government to push those ideas, but because of our nonprofit status, we had more autonomy and more flexibility to really reflect those priorities and set those agendas for government. And so what I have found over time is we want to keep building up the institutional resources inside government. Ultimately, that is our goal. What if the entire government budget was a health equity budget? What if the whole thing was? Like, that's where we go back to what's our big vision. But in the meantime, we need to keep having philanthropic dollars to supporting this work from the outside, really having what I call an inside-outside strategy, also supporting advocacy groups and others to kind of be jiggling things from the outside while we have our partners inside state government making changes as well.
Excellent. Thank you so much. Those are great ideas. I'm going to pass the mic back now.
Good morning. My name is Anthony Johnson. I'm with the Health Department, and my question is around healing. I understand your approach and the words that you've used to frame the approach and the wonderful work that has been done. When it comes to healing, does health and all policies, do we need to be more explicit with that? Because there are other frameworks like collective impact and things of that nature to bring people together, to promote collaboration. But there's some harm that has been done. You know, your wonderful chart on allostatic load and how people experience systems and things of that nature. How do we bring healing more to the forefront of these partnerships and these collaborations? Thanks.
Yeah, thank you, Anthony. This is a question I've been asking myself, and my team has been grappling with a lot recently. And as we have, we launched the Capital Collaborative on Race and Equity and have been doing our work has shifted over the last several years to really focusing on institutional and structural racism, on a daily basis. That is the bread and butter of our work right now. And, what's coming up is just the as you said, the tremendous harm that has been experienced by community at the hands of government, as well as by people inside government. And more and more people inside government who we work with are talking about the traumas and the hurts that they have experienced in their workplace, inside the institutions that we're trying to change. And they are trying to change the institutions while also bringing that those kind of personal hurts along with them. And so, we've been looking at, initially we were talking about trauma-informed approaches and have been kind of shifting to thinking about healing-centered approaches. And I have to say that it's been a bit of an uphill climb to, but I think that we're starting to get somewhere in terms of helping folks in leadership in our institutions really understand that this has to do with their work. And that if you truly want to promote equity in transportation or equity in housing or any of these fields, that healing and addressing harms has to be at the center. So many things have to be at the center, but this does too. And that when we kind of skip over the healing pieces, that we're actually going to fall short and we're not going to make the changes that we need. We were very fortunate just in the last couple of years, our state established an office, a Surgeon General, which is a new position in our state. And the person who was appointed, Dr. Nadine Burke-Harris, is an expert in adverse childhood experiences. And so she was doing a big push around ACEs statewide. And as part of that, we partnered with her to, she was doing a survey of jurisdictions across our state to understand what's happening around ACEs and kind of more broadly an understanding of trauma. And we were able to convince her office to also do a survey inside our government, of our government entities, to find out what their understanding is of trauma broadly and healing, and what kinds of approaches, if any, are being used. What we learned from that, not surprisingly, is we found a lot of gaps, but it's been very important to have that information to kind of build the case. And part of why we've established, with the new reboot of our Health and All Policies Task Force, there's now a roundtable on violence prevention and community safety. And that roundtable is presenting us with an opportunity to start to have some of these conversations in a multi-agency environment, not just on a one-off basis, but to really form a group that's going to be meeting in the long term. And that's where we're bringing in community partners to really help us ensure that we have integrity in how we're doing that work. So I don't have a great answer in terms of solutions or approaches, but just to say I really want to, I value what you're saying and what you're asking about, and this is critical. And I think we have a lot to learn and a long way to go. And And again, as I said earlier, there is no, in most jurisdictions, I've never heard of an agency or a department for healing. And there's mental health services, but that's very different. It's not the same thing at all. And so I think that this really is a key place for health and equity in all policies to play a role.
Thank you, Julia. We have one other question.
Thank you so much. My name is Benaias Asayas, and I'm representing Black Mental Health Alliance of Nashville. And first, I want to thank you for being here today, for having this presentation and discussion. And secondly, I want to thank you for identifying racism and not race as the driver of health disparities, because that's something that's often misunderstood. The question that I had is about health policy. And so in Tennessee, we have not expanded Medicare. And, that's a big issue because we have data that suggests that expanding Medicare will reduce racial and rural health disparities. And so in trying to, push this kind of policy change, with these kinds of collaborations that we're making, oftentimes the people who are doing the collaborating are people who are vested in these kinds of, institutional changes. But the, institutional backing comes from leadership, and oftentimes leadership might not share in the same politics. And so how do we push for, health policy change from an institutional level, and how do we, kind of push the leaderships to do what's, in the best interest of the people?
Yeah, thank you for that question. Well, I think for part of this question, I'm actually gonna punt and hope that folks later in the day who have more of a connection to the healthcare systems can really speak to the specific policy levers and where they see opportunities to make some real change. But what I will say just kind of generally is we have to make noise, and we have to be organized, and this is where inside outside strategies are really key. We need our advocacy groups and our community-based organizations to have the information. Like, they need clear information about what's going on inside government. They need clear information about the policy levers. We need to be more transparent with them about where those are, to make it easier for those folks to engage. I think that this, ultimately it comes down to government accountability, and political leaders. They're the bureaucrats who are appointed, and then there are people who are elected, and they do respond to public pressure. And it's hard and politically, in politically conservative climates, sometimes you certainly to make the case for some of these policy changes. But I think that, there's a lot of places in our country where these momentums are shifting. And so I think we just need to raise up our voices and remember that those of us who are, and I know that you are with the Black Health Alliance, other folks are working inside government. We may not be able to be vocal on some policy issues in our current role in government, but we can take our hats off when we go home at the end of the day, and we can still be vocal. And so I hope that those of us who really are inside of the policy process also are participating as, as citizens and residents.
Julia, thank you so much for gifting us with your presence and for all you're doing for the world and for this great example. Appreciate you so much.
Thank you. Thank you so much. It was really an honor to be here with you and with all of you. I'm so grateful, and I hope the rest of the day is wonderful, and I'm looking forward to hearing more about it.
Thank you so
and
much.
Again,
be well.
Please do take care.
So I'm super excited to hear what Jimmy has to tell us here. He is a senior research associate at Georgia Health Policy Center, and he's been working to improve public health by advancing the HiAP perspective of decision making. And he has expertise in the areas of system thinking, health impact assessment and healthy community design, and also some particular expertise in the area of maternal and child health projects that he's been leading, and also with the provision of training and technical assistance to local, state, and national partners related to HiAP. So without further ado, I'm really excited to hear what you have to share with us here, Jimmy.
All right, thanks. Oh, it's bright up here. All right, thanks, everybody. I am Jimmy Dills, James, if you're nasty, and I'm here under the banner of decision support tools, and that's very broad, and I was fiercely taking notes from what Julia was saying, and bear with me as I try to adapt and touch on what she's saying, and I only have 25 minutes. But really thinking about two key decision support, and what we titled this is sort of building room for possibilities and possibilities for collaborations by advancing a health in all policies mindset. Julia talked a little bit about, HiAP's an approach, not like one specific thing, and some of that ambiguity makes it hard to implement. And so one of the first tools I'm going to talk through is this iceberg model from systems thinking that's really a great way to start piecing out that complexity and getting to what are the mindsets that are driving the way the system works, and how can you unpack and untangle those? And those kind of conversations, while they might not seem like direct, here's a decision and it's going to affect this and do this kind of support tools, but it's part of that broader collaboration and moving towards this health in all policies mindset. And touching on, you don't even have to call it health in all policies. It can be quality of life, wellness, well-being, economic prosperity. All those things are health in all policies, and often when you're working across sectors from public health, it's a little painful for us to sort of give up on some of our language and use the language of the field that we're collaborating with. So that's the perspective I'm bringing on one tool, and then I'll talk about health impact assessment, which can anybody, if I can even see, show of hands, who's heard of health impact assessment or been involved in any? Okay, so a good amount. And it's an established tool for health in all policies. It's been around internationally for several decades, in the US for about 20 years. It was some of the seminal work that led to what Julia was talking about with California, a lot of the early work out there. We did some work here a decade ago in Nashville, or over a decade now when I was here, and that's why I'm excited to be back here and talking about this, to see, I was sitting there thinking, and it's like, I don't think I had a part in really planting the seeds, because a lot of this stuff was already going and happening over 10 years ago when I first came here. And so I think maybe some of the work we did with the health department back then under communities putting prevention to work started to expand this conversation and maybe help nurture those seeds to now see what's happening 10 years later, and that there's a large group like this coming from inside and outside government to talk about health in all policies. So I'm going to give a little bit of introduction to myself, talk about health in all policies as a systems approach, then go into health impact assessment, try not to get too down in the weeds of that, but really sharing that as a big, wide encompassing tool that you can pull different pieces out of, share a little bit of our story of how we used HIA to move to a HiAP mindset, particularly around affordable housing practice and policy, mostly in Georgia, but have also done that work nationally as well. And then share a list, and I assume we're getting all these slides out to you all, and so I have several slides at the end with links to additional lists, including that health note analysis and health lens and HiC checklist, and a lot of these other sort of more immediate tools that you can use, but I really lean on health impact assessment as the one that can really create the structured space for these cross-sector collaborations to really bear fruit over the long term. And then hopefully have time for Q&A, but we'll see where it goes. So again, I'm Jimmy Dills. I'm from the Georgia Health Policy Center at the Andrew Young School of Policy Studies in Georgia State University. And I will say, model the land acknowledgement. So I'm coming from land stolen from the Muskogee Creek people that's now called Atlanta, Georgia. And I'm going to skip over too much of my introduction, but I was asked to share a little bit about the Policy Center. And so Julia comes from the Public Health Institute in California. GHPC is our shorthand. We are a public health institute and the Public Health Institute for Georgia, and we're part of a network with Julia's organization and others across the country that forms the National Network of Public Health Institutes. I believe Tennessee has had one and maybe has a new one starting again, I'm not sure. But so Julia's is sort of outside of government. We are housed in a university that's a public university, so we are quasi kind of state employees. And so that affects the way we approach our work. And you can see our mission there to integrate research, policy, and practice. And that's what really drove me to this position at GHPC. And this type of work with health impact assessment, health and all policies, is it gets past just researching these issues and having findings that get published. And yes, we know disparities are bad, and we know they're driven by inequities, and so that's the end of it. This is the space, health and all policies, and this is the translational work that makes that real, does something with that information in terms of changing policy, changing practices, moving us forward as local communities, state communities, national communities, even internationally. And you can see our values up there, and again, there's a link here. There's a really nice little 5-minute video about our 20-plus year history and all the different things we've done in Georgia and nationally, so we do have a national footprint. But thinking about values, and values are somewhat synonymous with mindsets, and so I want to touch on continuous learning, the relationship aspect, justice, equity, diversity, and inclusion, and sort of those are really align with the values of health impact assessment and health and all policies work. And it's about learning over time and how do collaborations happen and building those from institutional relationships as well as personal, genuine individual relationships. And those networks are what make health and all policies successful over time. And Julia got at that of the long amount of time that California's been doing this for 20 years and has just now moved into the equity kind of language or the branding of it versus just health and all policies. It's now the equity aspect. And that takes time. And in California, as a large state, that takes a lot of time. In Georgia, one of the stories I'll tell about the affordable housing, that's been a 10-plus year journey to really move these things along. And so the question earlier about the urgency of this, I think that's really there, and it's figuring out how to address that immediate urgency, leverage that attention to address some of the deeper-seated systemic challenges that really are going to take a long time to solve, because it took us a long time to get here, and it takes a long time and a lot of collaboration to get out of those things, out of these challenges that have been created. So health and all policies as a systems approach. How many folks here have done sort of systems thinking work or would consider yourselves systems thinkers? A couple in the back, a few, okay. So Julia shared one definition. Wait, I'm going to go back and make sure I'm saying the things I wanted to say, because she gave me so many good ideas. So she shared that definition of inequity from Virginia Department of Public Health that talked about disparities are systemic. And I think that's why I gravitate towards this definition of health and all policies, as it's not about necessarily changing one specific decision. It's about changing the systems that create the decisions. And so getting that further upstream and thinking more deeply about how do you build trust over time to help have those people help you work upstream to do the different things, and thinking about different perspectives that are involved in systems. And a foundational part of systems thinking work is this idea of perspectives. You may have seen different versions of this sort of cartoon, but basically valuing different perspectives. One person sees the blue circle. The other person, from where they're standing, they see the red rectangle. And that creates our mental models of how that problem in the center, what's working, how is that happening, how do we view that is really based on our perspective. And it's only when we use these type of tools to create safe spaces for trust-building conversations, sharing our mental models, that's how we can build the more complete understanding of the challenges, identify those different solutions, and potentially help move some of the mindsets to acknowledge that all those different perspectives are valid and valuable, and some maybe more so than others in different perspectives. But really, I want you to think as you hear this, and maybe reflect on what Julia said and what you'll hear from the panel later, are what are these perspectives? This is a perspective I bring to this type of work. I'm excited to hear the type of perspectives you all bring to this work. Julia shared her perspectives from California. And so really just thinking, acknowledging that aspect, that we all have our own valuable perspectives from our own lifetime of experience. And some people, that's the lived experience of the challenges we're trying to solve on the ground in communities. Others of us, that lived experience is working in the details of those policies and that nuance and all that minutia. And when you have those working together, that's how you can translate some of those personal lived experience stories into actual policy solutions, because you're working together based on that broader, deeper understanding of the challenge. Another thing from systems, try to make it interactive. So another show of hands, who's seen sort of the iceberg metaphor, iceberg model of complex challenges? So Julia mentioned the sort of wicked problems, and that's synonymous with the complex challenges and complexity in the world. And this is a tool, an adaptation of this, and in the slides there's links to facilitation guides and things like that. But basically, it's a simple sort of 4-tiered structure And I'll walk through one as an example, and then encourage you as we think about this, I want to hear from you sort of what are some of the mindsets you think need to shift to do your work better. And so starting at the tip of the iceberg with the events. These are the things we see. This is what you're reacting to. And so the example I'll use to illustrate this is the traffic jam. We get traffic congestion. That's the event people see, react to. That's what's out there. But that event exists in a context of outcome. Why does it matter that we're sitting stuck in traffic for so long? It's because it affects economic productivity. It can affect your quality of life. It can affect, from a public health standpoint, morbidity, mortality. All these things can be sort of knock-ons of that event of traffic congestion. So if you're focusing on traffic congestion as the complex problem that you're trying to solve, and you're just looking at that, you can react to that. You can sort of, you're dealing with the symptoms of the problem, but it takes going deeper under the surface of the iceberg to get down to this next tier of the behaviors. Well, what's driving that event? What are the patterns of behavior that lead to people having to sit in their cars on the highway every day as they sit in traffic? And there's personal, individual kind of people behaviors that are part of systems, as well as the behaviors of the systems themselves. And what is the system doing? How is it behaving? And what are the patterns? So here we have people drive to work. If everybody's driving to work, then there's going to be more cars on the road. That can lead to traffic congestion. From the system behavior standpoint, we're building more highways. So the more lanes you build of road, the more space there are for cars, the more people are going to drive their cars, the more likely you are to end up with more traffic congestion. And so that behavior of our transportation infrastructure systems really building more roads is based on a deeper-seated structure that sets the context for that. And in this case, it's because we have this existing road network. The environment's already tuned and primed for roadway travel. And so the system just naturally moves towards building more roads because that's what we have. We'll add to that and we'll just keep dealing with that. On the human side, the structures can be sort of more the policies, the environments, the relationships between those things. And here we're thinking about, especially during the pandemic, working from home, the remote work policies at any given employer, that impacts the likelihood of people doing that behavior of driving to work. And then that, again, feeds up into that event you're seeing. But you can see already we're getting down lower and lower into the weeds of this problem. And so how do we think about remote work policies? How do we think about highway infrastructure and how our environments are designed, how our policies are working for or against the behavior patterns we want to see to affect the events we're seeing and the outcome? But then below that are these mindsets. And those are the beliefs, the values, the biases, the things that lead to our mental models of how the system is working. And that kind of thinking at that level, that's what sets the context for the type of structures you're going to be able to have. That's going to set the context for behaviors and so forth. And so here, employers, others might have a mindset that remote work is just not as productive. And so if you have that mindset, you're going to set workplace policies that don't allow for remote work. You're going to have more people driving, et cetera. I think that's a space where we've really seen a lot of mindset shift over the last few years, that you can be productive from home. Maybe we don't need to have everybody come into the office every single day. So that's a mindset shift that is changing the way workplace policies deal with transportation. On the other side, just sort of this common mindset that everybody can drive, everybody wants to drive, that's the best way to do it, and so that's how we're going to just keep building roads for people to drive on. And that mindset can be questioned. Maybe not everybody wants to drive. Certainly not everybody can drive. There are people who need to engage and interact in society in a place that can't drive to work. So if we're not thinking about solutions for them as part of that mindset that builds the context, you're not going to get those patterns of behavior that can actually reduce the event that you're seeing in terms of traffic congestion. So there it all is in one space. And the last piece of this is really thinking about this leveraging opportunity. And again, you can react to the events, and often you need to. There are things that you have to react to and deal with. In traffic congestion, that's where you get the I don't know what they're called here, but we have the hero trucks in Georgia where they come out and deal with the thing, move the accident to the side so the traffic can keep moving. That's reacting. But then when you're thinking about those patterns of behavior, everybody's driving to work. We're going to make hypotheses around what we predict there in terms of behavior. We can think differently about the problem and come up with solutions that anticipate some of the issues. Getting further down into the structural level where the policies exist, that's where you're really thinking about designing the structures, designing the context in a way that lead to those behaviors and the improved events. And then again, the highest leverage is down at the bottom in the mindset level. If you can transform people's mindsets around a challenge, that's how you can really start to identify broader and more impactful solutions that are sustainable over the long term. And so, let's see, where am I here? Mindset. So a couple of mindset things that I was thinking about and Julia echoed in my mind is this idea just simply from moving from thinking about health as health care to a mindset of a healthy community. Just that change in mindset opens up a whole wide range of opportunities to create structures. You can think about, she talked about policy, and especially those of us in government roles, we can't lobby, and it becomes very scary when we're helping people to think about policy solutions, but all they hear is policy, that's lobbying, we're a state agency, we can't do that. So shifting from this policy advocacy mindset to a more inclusive policy engagement mindset, just that little shift of you can still engage in policy, and those big P, those little p policies, there's a lot of space for policy engagement that's not advocating for particular legislation or doing lobbying. And just that mindset shift opens up the conversation for broader collaboration around these. Let's see, mindset, iceberg. Oh, and she talked about structures a little bit. Let's see, what was she was talking about the community participation aspect and some of the I had not heard that before, that they can't pay community-based organizations until the work is done, that kind of stuff. Those are the minutia of structures that you could change, that a government agency can work to change some of those structures to lead to better patterns of community participation, can lead to more community involvement in policy, but that takes a mindset that values that and realizes communities need to lead this work. This needs to be centered in the community experience. Once you have that mindset, then you can start to talk about changing those structures to actually support the engagement of communities in the way she was discussing. So I'm gonna pause there briefly and ask for you all to just popcorn if you feel comfortable to do so. With your work in health and health policies, what's a mindset shift you would like to see or have seen in some of your work? Anybody? Yes, in the corner. Speak up for us, please. Right. So police are needed. So the sort of first mindset is police are public safety and we catch crooks and we do that kind of stuff. But shifting the mindset around policing to it's about well-being. It's engaging in the mental health aspect of this. There's a deeper seated issue that's not just crime control. It's about working with people and their perspectives. And once you have that shift in mindset of policing, that can open up a lot of different avenues for different programs. Anybody have another one? Yes. Exactly. Yep. Great. Yeah, so I love that example because that was one I cut because I was like, I don't have enough time. But as she was talking about normalizing this, that normalizing, that's a mindset shift. Once you sort of see it and you normalize it, and we do equity, inclusion, justice, diversity, those are our core values that we build on, then you can have the more impactful conversations. But again, that's easier said than done, and we know to normalize that takes work. And so another part of systems thinking that's not really reflected here are the feedback loops that happen as you see changes in events and outcomes, and as you have more collaboration around behaviors and practices and structures, that can slowly lead to changes in mindset. And so that's one decision support tool. That's how you can support more collaboration to get more informed decisions by having these type of conversations with different people. And I encourage you as you go into the breakout rooms, unfortunately, I got another commitment. I'm not going to get to see the panel. But once I started using this iceberg years ago, I hear that and see that everywhere. And it's a really helpful sort of quick thing to just jot down and organize the complexity of what you're hearing. Like, well, what's the event we're talking about? Okay, what's really the behavior driving that? What are the structures? Where can we intervene? What's the mindset that needs to shift to help us do this better? And that's an easy way to view problems and the challenges you're talking about. So I hope maybe this sticks with you through the rest of the day, and you maybe jot down your own little icebergs of some of the issues you're hearing and the things you're seeing. But one way we can increase that leverage is, again, developing this health in all policies mindset. How do you get under the iceberg? Here we have 7 strategies from Asto Nacho. I think this one's specifically from Nacho. And I put those up because a lot of decision support tools will do different aspects of these, but they're all important, and they don't necessarily have to happen in sequence, but when they're all happening, when all these strategies are aligned, that's where you can really start to see change again over time. And I put that there to tee up health impact assessment is one specific decision support tool and approach that really encompasses all those strategies of aligning measurement, aligning communication, integrating health, building capacity for others to think in a different way about their problems. Also, we just wrapped up last month an update to the minimum elements and practice standards of health impact assessment, which I was a part of the group that did this, and it was a long journey for us to do it. We really updated the standards for this approach to evolve and be more accommodating of wider breadth of practice, and it really came originally out of a sort of environmental impact assessment, a very rigorous science-based, and it's still based in science, but as the practice has evolved, we know we need to figure out how to get more qualitative data, that storytelling aspect. How do you bring that into these decision-making frameworks and these decision-making conversations? Let's see, and perspectives. Oh, I missed one about perspectives. I'll go back to that right now. Thinking about those different perspectives, and she used the river and the upstream version, and I really like that she built on that, and there's so many ways you can use that. It's a pretty simple parable that can be really powerful to help people think about how these things are sequenced in space. And just from those perspective standpoints, we're doing some work with federal stakeholders around health and healthy aging and affordable housing. And it was a real light bulb moment when the partners from the housing side sort of spoke up on the call with the people from the health side and said, well, wait, you guys are talking about upstream, downstream. We know what that means. But I'm really getting the sense that your upstream is our downstream. And that really clicked for the people that were a part of that conversation to just really briefly in a simple statement understand, oh, we're public health and we're working way upstream in our standpoint, but the people coming from the federal housing side were like, well, that's, once you get the things built and they're out in the world, that's way downstream from what we do. Our upstream is how do you organize the capital? How do you get all the things, all the financing involved? How do you do designs? And there's so much further upstream. I feel like for public health, we feel like we've gotten upstream when we're collaborating with those folks. But once you start to understand their perspective on the challenge, then you can start to really see how deep that goes and how much expertise comes into that housing conversation. Again, sort of just focusing on values as part of mindset, and you can see those align with some of the values of my organization, some of the values and the issues that Julia was talking about, and the definition there, but really HIA is meant to, well, actually, I'll just go right into the minimum elements. There's a lot of words up there, again, hoping that you guys have this to reference later, and we'll check out the practice standards document. But these 10 things are the things that make HIA a little different from the other tools. When all these things are going together, that's when you're really doing HIA. And first, it's a prospective approach. It's looking at decisions that are under consideration and influencing an existing decision-making point. And thinking about health and all policies as a mindset, as a systemic approach, that's looking at that whole system of decision-making. So within that, HIA is nested because HIA focuses on a specific decision and can bring together the stakeholders to inform that decision. And that's a piece we sort of changed is to be considered an HIA by what the Practitioner Society defines it, and it's somewhat arbitrary, but we're experts in this, and this is what we think now, that rapid, intermediate, comprehensive, there's different scales of HIA. All of those need to engage stakeholders in some way, people who are either affected by the change, the decision you're looking at, the people who are making those decisions, but it can't just be you as a health person making some notes and some ideas. That used to be called desktop HIA, and now we're trying to move away from that language so that HIA, a minimum element of HIA is engaging stakeholders that are affected by the decision. It systemically considers a range of health impacts, so you rarely do an HIA on one specific, we're just going to look at injury here, but rather you talk with the community, you talk with those stakeholders and expand that and talk about not just the injury rates, but what are the behavior rates behind that? How does that affect obesity? How does that affect job opportunities and economic development? But really having this broad perspective of what impacts can be to, again, make those conversations more inclusive of the people who need to hear them, who need to be a part of adjusting and working with those decision-making spaces. It characterized, wait, let's see, where am I? So then this is some of the nuts and bolts of it. You got to provide a baseline. Look at, what are the conditions now? But that's not just health conditions. That's some of the historical conditions, and I like that Julia raised that as part of their work with racial justice, and there's so much history and so much painful history there, and you got to find the space to be able to include that, and that's in HIA, part of the baseline. Why are we here today? What are the historical implications of of how we got here and what can we learn from that to go forward. And sometimes it takes time with relationships to build the trust to have those challenging conversations in a way that is not necessarily expressing blame or rehashing past grievance. It's really looking at those past experiences and making sure we don't have them again. And how do you pivot from that to something forward-looking, which then is the next part, where the HIA analysis actually is focused on what are the potential health impacts of the decision, and then the real key piece is developing recommendations based on what you find there to actually influence that decision and target that decision with evidence-based predictions of potentially where health can be impacted positively or negatively, and you want to enhance the positive, mitigate the negative, and that really creates a space where if you're doing it well and doing that inclusive engagement aspect of it, people will see themselves in these decisions and see how this recommendation came from the story we heard from that community member combined with this piece of data that led us to be able to make this recommendation that we think will make this project that much better because of it. And so when you're stringing all that together to the recommendation aspect, that's what HIA gets you a little more so. And I don't want to diminish the value of the other tools that are a little simpler, because I know there's value in simple tools as well. But a lot of those are just sort of checklist and like health saying, here's some information, use it. Here's how we think we could use it. HIA makes that, here's our health information. Where's your information coming from? Let's put those together. Let's collaboratively interpret that and turn that into something useful for the decision. And through building those relationships, again, that's how you can sustain longer health and all policies work, by building collaborations through tools like health impact assessment. Then finally, the back end stuff, it produces a report. It's really good if it's publicly available. At the very minimum, you want the decision makers to see it and the affected communities. And then this is something we really softened in this version of the update, is evaluating it. So many HIAs got funded through the years, but not funded for follow-up. And so a given HIA, the minimum element is just to propose ideas for how can you, who can continue to be involved in these decisions? Who can track how these decisions were implemented? Who can track how HIA recommendations might have been integrated into what's happening? And that requires sustained involvement of different perspectives. And then finally, proposing the indicators and things to measure the health outcomes, to sort of test those assumptions, see if things are improving. I read an article or saw something recently. It wasn't from an HIA, but it was a really interesting article from Texas about the highway signs. We've had 3,000 road deaths on Texas roads this year. And those are supposed to be a safety improvement thing. You're supposed to see that and say, oh my gosh, I need to drive more safely, and I'm going to do that. Boy, they were able to design a study to show that actually injuries increase after that, because that distracts drivers. That powerful message messes with your psyche enough that there was, I forget, it led to like 16 more deaths in Texas over the course of a year or something like that. But they were able to tease out that effect, that this nudge for healthier driving behavior actually was counterintuitive. And they would not have known that if somebody had not been following that and testing that assumption that, it's made in good intention. Let's show how dangerous roads are, and that might make people drive more safely. Turns out, that's not the place to do that. And so an HIA, sorry, I totally went on a tangent there, but the HIA thinks about that. Who can track that? Who's going to track the injuries over time? And that's where it can integrate with public sector, public health surveillance, and the issues that people are already tracking data on, community health needs assessments. Those types of things can be the place where you might be able to see long-term changes in health outcomes based on what an HIA does. Very quickly, just trying to illustrate this is our journey from HIA to HiAP and affordable housing mainly in Georgia. But I'll put this up first and I'll ask everybody, but particularly people coming from a public health perspective, looking at this figure, what's something you notice here maybe? It might make it different from other figures you see that are similar. Overlap, so a lot of the things are overlapping. Yep, what else? There, oh man, I want to get you a gold star. I need to see who you are, because you said all the right things. Exactly. So much of our work in health, and it's not necessarily a bad thing. We're working in health, so health is the center for us in the public health side. Our perspective is everything flows from health, and health is the core thing. But if you take that message out to people who are working in housing and affordable housing and are passionate about that issue, housing is their thing. Housing is the center of their perspective on these issues. It still overlaps with all the things we want to talk about at health, but just that subtle thing of moving health and environment to one of the things around housing instead of the thing that housing is around changes the conversation and the mindset for collaboration. And this came very specifically from some of this work where once we showed this figure, the housing people immediately saw themselves in the work more clearly, and the public health people had a real aha of like, oh, health doesn't have to be at the center of the diagrams that illustrate these frameworks and all this type of stuff. So again, thinking about what are these small changes you can make that can precipitate mindset shifts to lead to collaborative relationships. And that's what we did here in this timeline. We spent a few years doing specific health impact assessments on housing issues, first in Texas, and then we did one in Georgia on a specific policy and really got in the weeds of that and worked with our state housing finance authority to do that. Then we were able to secure funding to do a follow-up that took that state-level finding, those state-level findings and recommendations, and then looked specifically how they rolled out at specific affordable housing development sites around the state. And that got us in the conversation with affordable housing developers in an actionable way. It gave us a thing to collaborate and help them make their projects better and more healthy. Not that they don't need to do the project, but you're already getting this funding. How can we shift the policy to make it a little better for health, or a lot better for health over time? So with that, and with the trust built through those relationships and that engagement, around 2017, we started to see this shift in mindset of broadly the affordable housing development community and policymakers in the state. And one of our leaders from that side really said it clearly. You know, I used to, and he was is still an affordable housing developer, and he said, I used to think of this always as, you know, as bricks and sticks. What we do is we build housing. The policy tells us where to build and how to build, and we build and we do things, and then we move on. But from engaging with us about how to think about how that affects health, how health affects where housing can go, all the different ways you can think more broadly about housing, shifted his mindset, and this is reflected in other data we collected from our stakeholders, of housing as a platform for population health. And again, just thinking about what they're doing as this platform for health and well-being opened some of the skeptical stakeholders' eyes to, oh, if we maybe do offer the opportunity for on-site health screeners to come out and do things every few months at our properties, that could help promote health among our residents. And to them, healthier residents are healthier tenants that pay their bills on time. They have less evictions because of that. So that's their mindset of why it's important to have healthy residents. That might not be exactly the way public health thinks about the reason to have healthy residents, but it gets them thinking in that space in a way, again, with those perspectives on the same issue coming together to think of different ways. So that sort of mindset shift really led us into this opportunity to get additional funding from philanthropy. We also made some policy changes that created a space where developers were actually paying us through an intermediary to do consulting for them on housing applications. So we really got deep in this system and started to expand and do broader work, working with public housing authorities across the state, engaging the systems of partners in those local communities, the developers, doing other follow-up actions. And Julia also mentioned the sort of the time it takes, and you sort of, if you lead with community engagement, that is valuable, and that can get you to a certain level. But what we identified early on is, well, if we're working at the state level of this, and we're bringing ourselves into the state affordable housing development space area, that the way that system already works, the developers run that policy. They have their meetings. The developers basically get to write that policy each year for how the state disperses tax credits to incentivize development. And that's really wonky. And there's not an existing space for community members with lived experience to come into that and provide useful information or have the capacity to even engage in these topics. And so we saw that very early on and acknowledged that as a shortcoming of our early HIAs, that the equity dimension was really brought in by proxy through agencies that advocate for residents and some of those. So it wasn't completely absent, but we didn't have that lived experience perspective. It took this whole journey to get us to a point now where we have the trust of the state agency, we have the trust with the developers from the information we've given and shared with them on their applications, and we have the trust of the local housing authorities that we really are bringing something worth talking to their residents about and getting the residents in the room to tell us about their lived experience in these units. And one more point here and I'll move on. There's a big capacity building component of this project as well, where we're bringing these people together and again, simple wording. I think we originally called it a healthy housing learning academy for all the stakeholders to be involved in, including residents. And then learned really quickly, what if we call it Housing and Health Learning Academy, again, putting housing first because that's the group we're trying to get to do things differently. And that shift, again, brought more people into these meetings and had great conversations. We had data. So this is skimming the surface of this project. But basically, we created a space that did not exist before for people from a local public housing authority, sort of like property manager people, resident service managers, resident leaders, the developers, the architects, so the money people, the design people, and the state policy people to actually sit at a table for an entire day and collaborate and look at data and just to see the aha light bulbs go off of the developers hearing that, oh, the way we do noise insulation affects the way I sleep, that affects my mental health, that affects the way I'm able to live my life. And to hear a resident say that and it be reflected in the data we were able to bring and then have that constructive conversation where those perspectives are being shared really led to what we're hoping over time, and this is again where we're positioning ourselves to hopefully be able to monitor those changes over time, see improvement in health for these residents in these communities across our state, and hopefully creating a model that can be used in other states as well. So that's a broad thing. So these are sort of the tools, I guess, I'm sharing with you, or this iceberg. I encourage you to think this way today if you can. HIA on the right, and then these strategies, and just how can you leverage different tools and decision-making support offerings to synchronize communications and messaging around an issue. How can you think about coordinating that funding and investment in a way that expands the tent and gets more people involved? You're not relying just on government funds or philanthropy. You're relying on both. You're relying on developer fees. That's what we did in some of our work there. And then just to end, again, hoping you're getting all these slides. So lots of resources on systems thinking. I'll say that's how I ended up doing maternal and child health work very unexpectedly now over the last 4 or 5 years, is through systems thinking for their complex challenges. MCH, Maternal and Child Health, thinks a lot about social determinants. They had not been at the table in much early HIA work because that work went through environmental health, went through chronic disease, sometimes went through a policy office or an equity office, but it didn't go directly to maternal and child health for the most part. And so there's a big mismatch there, and that became an opportunity to work with maternal and child health stakeholders through these national centers to build capacity of that workforce to think this way. And so there's these intra-public health silos to break down, as well as cross-sector silos as we think about bringing these perspectives together. So you'll see that in a lot of these tools. If you look at them, they come from a maternal and child health perspective, but they're broadly applicable. Health impact assessment resources galore, ever-evolving field. Encourage you to check those out. Other decision support tools, just to note that they are out there. I have limited expertise in any of these. You got the stuff that I know the most about, but I know John and some others are going to talk, I think, about how they maybe have used some of these or similar tools in their work locally. And then encourage you, all of you, you're here today in a Health and All Policies Summit. You are Health and All Policies practitioners. Join SOPHIA, formerly the Society of Practitioners of Health Impact Assessment. We, again, are sort of rebranding to be, SOPHIA is now just the name of the Network for Health and All Policies Practitioners. And that's a great place to go and learn, get to meet people like John. Well, you maybe already know John. I'm gesturing to you because I can barely see you through the lights. John, Julia, that's how we connected to have a conversation about this meeting beforehand. And it's a really informal network, very low cost to join, $50. And I think we have even some discounted rates for students and others. But that's where we talk about the field and how we get involved in hearing these stories from others and how Health and All Policies is unfolded across the country in a lot of different ways, in a lot of useful ways. And it's just a great network of people to be involved with and can energize you for this work if you're getting stuck locally and being frustrated, participating in some of these webinars and hearing what's happening. And we had somebody from the, oh gosh, I'm going to say the wrong one. I believe it's the Choctaw Nation in Oklahoma. Come and talk about Health and All Policies, what they're doing there at the tribal level. And just hearing that gave me energy for the whole next week of like, yes, this is still happening. I can solve the problems I'm working on because I have the support of others out in the country doing this work. So with that, I'm pretty sure I'm over time, but questions or pull me off stage, whatever you want to do.
Going back to your housing work, you talked about the work that you've been doing with developers and the state government. How did that work account for gentrification, absentee landlords, and maintenance practices for existing housing?
All those things came up as part of it, and let's see. So gentrification. So that, those are certainly loaded terms and big issues. So one specific aspect we did to hopefully help affect that. Yes, sir. Maybe displacement. Well, one with the Georgia Homes for Healthy Futures project, the one we're currently working on, that is through rental assistance demonstration, RAD conversions. So they're doing environmental sustainability updates to old stock of public housing. And we saw an opportunity in that to expand that environmental health conversation to a broader health conversation with these stakeholders, building on those relationships we had. And a key piece of that I wish we had been able to go deeper on, but just the structure of the project sort of made it a little tangential, but was the relocation plans for those residents as they had to move out for their units to be remodeled and rehabbed. It was interesting working with the developers and the public housing authorities for where could they have stock in their portfolio to give the folks that had to move an opportunity to move to another property, same rent, all those kind of things, but then have first right of choice to come back to their former unit once it was remodeled. And so that's one example of that. There's broader data sets and things we were using at the state level, which unfortunately, because the state public health department has not been very deeply involved in any of this. We are the ones from the public health, our Georgia GHPC, representing a public health perspective. So we're kind of at the subject to the data sets they had, but they had a really great community index of about 22 different 22 variables that characterized at the census tract level who was most likely to live there and what were some of the key health concerns at a state level. And we were able to get the policymakers on the housing side to integrate that into their incentive model that previously was just like high poverty census tract. If it's high poverty, you get extra money to try and build new housing there. This expanded that to, well, what if you actually look at the demographic makeup and not just poverty as the one indicator of need in the communities? And so for a couple years there before that data set expired, they were actually incentivizing housing in a more nuanced way into communities of need in a different way that is a couple steps from reducing displacement, but is really, to me, an example of the kind of thinking that needs to happen and acknowledging sort of the market forces that the developers are dealing with. And that's part of the learning, is just hearing how they talk about this. And it's not any one developer broadly trying to move these people out and make this a better place and that kind of thing, but it's more, these are the properties we can secure the financing to develop, and this is where they are. And if we're only looking at high poverty tracts as the place to do that, that's going to have ripple effects through the whole housing system. Once they expand that to look at different type of places, there's more Hispanic seniors with limited English proficiency who are likely to work in manufacturing jobs in this area. That tells you more, and that's able to then say, well, here's the type of housing that might work best here, and the state incentives for financing follow from that, again, rather than just, here's where everybody is impoverished, let's build affordable housing here, but really looking at that nuanced aspect to decentralize it. And we're starting with some of the the affirmatively furthering affordable housing, fair housing ruling and stuff that's coming out. We were just having conversations recently about how can we work to help the housing system in Georgia adapt to that ruling that is aiming to, disperse poverty and not over-concentrate it. And I'm going to stop there because I will ramble on and not know my details of that. But we're very much in that space, building on those partnerships we've created through this existing work to have those conversations as trusted partners, not coming in as an outsider saying, you need to do things differently this way because of this problem. We've already had that conversation, so now we can actually be in that structure with those people. Yes, ma'am.
Thanks. Hi, James. Kanika Young. We actually met a month ago on Zoom with your colleagues, Angela and Bill, so it's great to see you in person. I appreciate your presentation. And the moving housing to be the center of the systems model was really an aha moment for me, because I'm thinking back to my work in health policy and equity and focusing on access to healthcare. We've heard things like your zip code is the main predictor of your life expectancy, and there's this whole movement around housing is healthcare, and we know that proximity to resources is really important. And so I was just like, why didn't I think of that before? So thank you for that aha moment. But my question is, When you made that shift, did you get pushback from your traditional healthcare stakeholders? And if so, how did you deal with that?
Not really, because you're asking. Thank you for that question. It's because they weren't super involved in the piece of the work we were doing, and so it was kind of us representing health and recognizing that we're not talking to a health audience, so we need to shift the housing, and then the healthcare partners sort of come around it. So one of the things that grew out of our HIA recommendations, and again, this sort of like being able to track and monitor this stuff, is purely because of our relationships and being able to piece together these projects to stay involved with DCA, is the state agency I'm talking about, the Housing Finance Authority, and like being able to be there with them and talk about those kind of things. That it got a policy where they created this healthy housing initiative, where one of the incentives, one of the things that would get them, score them better to get the tax credits, was to secure an agreement with a local health provider to come on site and do those screenings or some kind of health programming. And so we were helping them with those parts of the application. And that's where we started to engage with the healthcare community. And what we had created was a real space where if there was that right local partner, and some of our work broadly across our center that works more closely with healthcare policy and those types of entities, we could leverage those relationships to bring those people in at really that ground level. But then immediately saw the sort of difference of, well, the housing people, they're still sort of bricks and sticks. That's what they do well. They don't necessarily provide medical services well. Historically, there's a lot of models now where that housing is healthcare, and co-locating services is a strategy. But if you're thinking about that upstream, downstream, that's midstream. That's certainly upstream from clinical care, but it's still potential. And this was the tension we were hearing from them was, why do we have to do this now? That's why they hired us through a third party to come in and look at the data, tell them what would be work there and who the partners might be, and then secure the letter of intent and all that kind of stuff with them, because they saw it as, that's not what housing people do. We're housing developers. We don't necessarily do that. We're good at building things. But the policy space, this sort of meeting the system where it is to change slowly, got us where we went with that, even though from our perspective, we would like them to do more design things and more of that location stuff and that further upstream about how is the housing designed and where is the housing and how does that affect your access to health care and health promoting resources in the community. But they weren't that far upstream yet. They weren't able, their mindset didn't allow them to get that far. So we met them where they were of, okay, we can be a platform for health. To us, that means a platform for health care. So we'll just, offer this, and we'll have the blood pressure van come from the local pharmacy every few weeks and do tests. And that's not a bad thing, but it's still not getting that highest leverage solution, but it's part of that journey building up to it. So I hope that kind of answered your question.
Hello, thank you for your presentation. My name is Raquel de la Huerga, and I work for the Health Equity Bureau at the Public Health Department.
Great.
And I was interested when you were talking about data as a part of the HIA process. I'm curious to talk about the equity issues that come up with using data as your decision-making tool, and specifically in terms of humanizing data or having data represent the intersectionality or the nuance that exists in our communities that is felt by the community, and on top of that, looking at how data, census data as an example, has misrepresented what is experienced in real life.
Mm-hmm. Sorry, what was the question? I would just say yes.
The question was, how are you approaching equity issues in data, and how do you account for the issues that I named with the data that exists in moving forward and making sure that your decisions are equitable and not solely based off of data that can sometimes misrepresent what is happening? So
I'll kind of punt that one, and I am not the data wonk on our team. Michelle Marcus is our data guru who can really get down in the weeds of that. But I think broadly, it gets to some of what Julie was talking about of how do you engage the community in conversation and in collective interpretation of the data, because there's the existing secondary data that you can pull and that you have, and you're right, a lot of that comes from inequitable, unjust structures that have permeated for centuries that lead to the way we classify people and problems, but that's the data we have, and the key is to bring in the people with lived experience to help interpret that, share those stories where, well, that doesn't make sense to me. I would try to use one, what's the census category? The the one that lumps everybody together, that's like Asian, Pacific Islander, Indigenous, that one. And this was actually from maternal health, child health work the other day that came up, and they were just like, these communities are so different, and unfortunately that number's so small from the big picture that like, there's reasons that you gotta have that category to have enough to say something, but once you're saying that something, you need to take it to each of the components, the people who are making up those groups, and if you're really talking specifically to an Indigenous group, have them interpret that, share their stories about it, and see where it aligns and where does it mismatch, and then where it mismatches, really lean on that experience. And to bring that experience into projects, it gets to that sort of funding and compensating people for their time at a reasonable rate, and it's not just a $5 gift card, because if I'm getting paid whatever, $50 an hour to be there as an expert, and I'm only paying a community member $5 to be there, that immediately perpetuates that inequity. And so how can we create in our budgets and our funding structures for our projects really carving out that space? And that's something we've done at the Policy Center over the last several years. Have really started to systematize that in our own processes of, we're looking at data that's not coming directly from the people we're serving. How do we get those people we're serving to be an authentic part of that conversation? And again, it takes time and it's hard to do, but just the fact that you're even asking that question in that way tells me that Nashville is in good hands thinking about data from an equity perspective. Yes.
Hi, my name is Lauren, and I work in the WIC program, so maternal and child health. But one question, I really appreciate your iceberg. I've seen it so many times, but it was kind of an aha moment to think about it again and get reminded about it. When we are looking at some of our events that are so shaped by the mindsets down below, do you have any guidance or suggestions or advice on how just not getting frustrated or anything about trying to change those mindsets, especially when a lot of your mindsets are set by big P policy, and just anything about that?
I would say, just take a deep breath. This is frustrating. This is hard work to do, and you can get burnt out. But then your phrasing there too, the mindsets are affected by the big P policy. I would see it the other way. There are mindsets that create those big P policy structures, and those and especially, thinking about those different perspectives. We're so polarized now, and it's so easy for people to essentially, sort of revert to their core mindset and not want that to change. And you can see it as you're thinking about these problems, like this thing we keep seeing that these same people are saying is a problem. It stems from this racist mindset, not the race, it's the racist aspect of it, or the systemic injustices, or all these things, and figuring out a way to, and Frameworks Institute, and I know Robert Wood Johnson Foundation has some pretty good resources about how to talk about equity to different audiences, and sort of, again, using the things that they care about, what's forming their mindset, trying to, again, build the relationship and find the space to have the conversation about mindset. That can be the power of the iceberg. Is we're talking about WIC. What's an event from WIC?
Well, I mean, like requirements for either staffing education or requirements for like the process that has to be done.
Okay, so an event might be the WIC recipients are not satisfied with what they're receiving. Then the behavior would be the people delivering the services aren't talking to them in a culturally appropriate way, or it might, sensitive way. That might be the problem. The policy is, or the structure is, how are we training those WIC people on the front line to do things in a different way? And the mindset that can facilitate better training against implicit biases there would be that those exist, that this problem is deep-seated in the history of racism and in the history of poverty in our community, and being able to find the space. And that's the tricky part, I think, is like, where can you create these spaces? HIA, to me, is one really good tool to create that kind of space. But there's plenty of other places and meetings, and I hope follow-up conversations, like Julia said, like, go have coffee with somebody from this meeting that you don't know that's in a different sector and talk about things. But creating that space to then unpack that mindset aspect of it. And something I don't think I mentioned earlier is, what's his name? It's conversational capacity is the tool, the term we use, but basically this idea of candor and curiosity. And there's research out there on collaborative networks and how do you collaborate when there is that tension, and it's about asking and understanding the mindset, and that might get painful and challenging, but being able to not just other that mindset and say, that's never gonna change and you're just a part of the problem, but rather, okay, I'm hearing you say it this way. I'm curious, how do you think that? Why do you think that? And again, it's easy to sit up here and say that and say like it takes trust, but that is the key part, is who can you talk to about that aspect, and how do you build the trust to have a mindset level conversation and be able to clearly show through the iceberg or other tools that it's this mindset that's really affecting, that limits our policy opportunities to change the way WIC services are delivered to actually affect the health and well-being of women, infants, and children, per the name of the program. So I don't know. And to acknowledge the frustration. And I think that's a bigger conversation just about, especially in public health, but I think society-wide, just burnout over the last few years and what's happened and the way public health profession has sort of been treated and demonized in a lot of settings. That makes this work even harder to do. And so finding the energy in your peers, finding the energy in these networks to see good examples and aspire to that, and take care of yourself first to be able to participate authentically in these types of conversations. And that takes time and resources and an investment in yourself to be able to not you, everybody, to not get like overly frustrated by this, but own the frustration. Know that it's frustrating because it's a complex challenge. It is a wicked problem. And you need to take care of yourself to be able to, again, authentically come into those conversations. I don't know, I feel like I'm talking like a self-help person now, so I don't know if that's helpful or not. Anybody else? Is that it?
Any other questions?
Okay. All right, thank you. There, thank you.
Thank you so much, Jimmy. As a clinical psychologist, I can validate that your advice was also clinically sound. So very, very well done.
Well, hello everyone. My name is John Vick. I am with the Tennessee Department of Health. I'm the interim director of the Office of Primary Prevention. I'm going to talk a little bit today about the Tennessee Livability Collaborative. This is our state health and all policies initiative in Tennessee. It is definitely not the only way that we do health and all policies at the Tennessee Department of Health. It's a way, not the way, but it's one that I co-facilitate along with Leslie Meehan. It's, I think, a really interesting model. Oh yeah, am I not enough? Is that better? All right, did you hear anything I said? Okay, great. All right, so I'm gonna talk a little bit about the collaborative as a way, not the way to do health and all policies, but it's a model that's worked well for us. I do want to acknowledge that the department is doing a lot of other things like HiAP outside of this before I talk about it. We have county health councils in every county in Tennessee that the department helps to support and build the capacity of. We also have healthy development coordinators who work in local communities across the state as advocates for building healthier built environments. And then we also have a health disparities task force at the state level out of our Office of Minority Health and Health Disparities. So we have a lot of other initiatives going on as well. But the Tennessee Livability Collaborative has been around for about 6 years. It started off as a conversation between 4 departments, including the Department of Health, who agreed that there was value in us getting together regularly and talking about opportunities to collaborate and align the work that we do, because so much of what we do as state government agencies is really working toward the same goals and the same end. So how do we make sure that we're not working in silos? How do we make sure that we're identifying those opportunities for collaboration and that we see our goals as shared goals? So it started off with 4, we're now up to 21. We are a voluntary group. We were not created through executive order or legislation like many HiAP initiatives. It started with a conversation. Nobody's required to attend, but we've had consistent attendance. We tend to have between 20 and 30, sometimes more people attend every other month when we meet in person. It is a working group, but we don't always take on big initiatives. A lot of what we do is talking about the work that we do and identifying opportunities for collaboration. We don't have any funding. There are two of us at the Department of Health that facilitate the group, but we don't have any dedicated staff other than that. We don't have any funding, which is both a good and a bad thing in different ways, and I can talk a little bit about that if people are interested. But yeah, so we've been together as a group for a while now. At the 3-year mark, we decided to do an evaluation of the group to see if we were accomplishing our goals and to see if there was value in having a group like this that met regularly. What we found through that evaluation is that we were seeing increased collaboration among the agencies that were part of it. We have dozens of examples in the evaluation report. That's online. If you Google Tennessee Livability Collaborative, you can find it there. So lots of different examples of departments collaborating on projects, reaching out to one another to participate in events or in assessments or producing reports or partnering on programs and funding. So a lot of great examples of concrete examples of collaboration that happened. Maybe not necessarily solely because of the collaborative. It's tough to attribute some things to just one effort alone, but certainly many people identified the collaborative as either being the sole reason or a contributing factor in a lot of those collaborations. There's been a lot of talk about mindset. I think that's been really important for us. As we've worked together as a group, the evaluation also found that people felt a more common sense of shared purpose and a better interconnectedness between the work that we were each doing as state departments. We also did create some unique initiatives as a group. I'll talk a little bit about those in just a moment, but I did want to mention too, so we have mostly just state agencies, departments, and commissions, and we then have also 3 academic partners that are part of it. This is just solely for public state entities. Part of that is, I think this was mentioned earlier by someone, it's kind of a safe space for us to really talk about the work that we do and vet ideas, talk about challenges that we have. So we've limited it to that for now, but we could certainly open up the group in the future, and I think there are lots of benefits to doing that as well. One of the things that we are currently working on as a group is creating a set of livability indicators for the state. So I haven't really talked about the term livability. You'll notice we don't call our initiative a Health in All Policies initiative. We don't lead with health. And part of that is because we've worked very hard to create a neutral space where everyone can come together, and it's not something that you're doing for the Department of Health. It's something that we're all doing for one another. And so everybody sort of sees how their work relates to this concept of livability. There's no Department of Livability, but we all see how we touch that and are trying to work toward that. So that's why we call it the Livability Collaborative instead of a HiAP initiative. And I loved Jimmy's diagram where he had housing in the center, because I think what we're really trying to do is kind of an informal version of that where everybody sees themselves as the center of the diagram in our group. So we did identify as a group some opportunities where we felt like we could be impactful. One of those was thinking about service utilization. We have a lot of resources in state government, and many of those are underutilized, especially by communities and people who need them the most. So one of the things that we did early on was engage local stakeholders in 2 distressed counties in Tennessee, economically distressed counties, to work through our Department of Economic and Community Development as they were developing their community and economic development plan. They're called 3-star plans. We actually brought at the time all 12 agencies that were a part of our group out to those communities in person. We listened to what their priorities were and what action steps they had as part of their plans. And we talked about what resources we had available that could help support the implementation of those plans and build relationships between state government and local stakeholders and communities. So just one example of something we've done, I'll go back to the livability indicators. So one of the things we identified early on as a group when we developed our theory of change was that we wanted to make data more accessible, and we wanted to have a publicly available data source for the state that touched on all the different things that relate to livability. So we've been working hard as a group on creating a set of indicators. Some of those are internal to state government. Some of them are produced by other entities outside of state government. We have about 120 indicators in our list so far that we're working to vet. But the idea is that we'll make those publicly available and that we would like to share them in a way that puts data in context. So this came up earlier. Sometimes the data can misrepresent things. We've talked a lot as a group about wanting to make sure that we have indicators that really are things that we can impact, but then we can also put them in context and tell stories alongside the data so that it's not just numbers, but it's something that includes both qualitative and quantitative data and stories around issues across the state. So we're working on those. Hopefully they'll be publicly available soon. We've actually already started using those indicators to inform our current state health plan, which we're working on right now. Part of that is an analysis of health across the state, and our current state health plan actually started with that draft list of livability indicators, which collectively really represent what we would call the social determinants of health. It's everything from active transportation to affordable housing to educational attainment, community engagement, a lot of different things. So we started with that list, and then we're able to work through the collaborative members to get their expert opinion on the best indicators for us to measure for the state to look at health, and then also to get a little bit more context for some of those numbers. And again, to build relationships, just the process, I think, of developing these indicators. There are lots of tools out there for looking at data that are available nationally, but we really want to go through the process, because the process itself, I think, has been an important outcome for us to partner, to create something together, to learn about one another's work and priorities. So just an example of something that we're producing as a group beyond just learning in our working group meetings about the work that we're doing, identifying opportunities for collaboration organically. And so I think I'll stop there, but glad to answer questions during the Q&A portion if others have questions about the work that we do. Thanks.
Awesome, thank you, John. John Vick, just to be clear. So I wanted a quick update for the facilitators for the breakout sessions later. Actually, during the Q&A portion, if you wouldn't mind, start going out to meet with Tracy and Latrice, that would be great. So we're going to pass it now over to Raquel, who had the wonderful question about data. So I'm more excited to hear about some of the things that you're leading here, and go from there.
Sounds good. Hi, everyone. I think I have slides available, but if not, we'll move forward. My name is Raquel de la Huerga. I work for the Health Equity Bureau at the Nashville Public Health Department. And to kind of tell a bit of a story of how we got to some of the work that we've been doing in the health and all policies space, I'm going to give a little bit of history that relates to Tracy Buck, who has helped organize this event, as well as Tom Sharp. Both of them are kind of our veterans at the Public Health Department who have been leading health and all policies work for years now. And most of that has been conversations and convenings of people across Metro government to talk about different issues and talk about what's going on in their spaces. And when the Health Equity Bureau launched at the Public Health Department, which was a little over a year ago, we were brought into conversations about how to build in equity into this process related to what Julia was talking about in terms of health and equity in all policies. We see that fully. And trying to get to a point of how do we make this practical for the people that we're meeting with on a regular basis. In our health and all policies coordinators meetings, we're regularly working with general services, planning, the juvenile court, water, et cetera, and having conversations. And Tracy has done an amazing job in terms of training up those people to understand health and all policies as a framework. And that's what we've talked a lot about today in terms of this theory of how people should get together, how we should be having conversations, what we should be talking about, what should be at the center. And our hope was to create what we're referring to as a tool to kind of make that process easier, because your jobs are already so complicated, whether you work in government, nonprofit, private sector, et cetera. Having conversations about health is difficult, and not everyone's going to go out and get a master's of public health and have a really strong understanding of all of the nuance that goes into this. And so part of our desire was, one, to have more facilitated conversations where the public health department was facilitating those conversations and guiding what was being discussed when it comes to health, but then also training up our peers around Nashville to be able to take the tools that we could give them and move forward in their projects and guide decision making within their teams to center health. And so the way we kind of have gone about this has been a big trial and error process. We've been at it for about a year in terms of trying to build what we have called the Health Lens tool. And you might be thinking, what do you mean Health Lens? And that's just a nice way of us trying to frame out what it looks like from a public health perspective to see these issues. And so what we've been talking about today in terms of if you are a housing person, you see housing as the center of everything that you do. And I think there's been really fruitful dialogue of whether or not health should be at the center, and I think that varies, but equity should definitely be at the center, and when it comes to having conversations that are thoughtful about health, it is good to have designated conversations that discuss those issues. And so we created this Health Lens tool that asks questions to kind of get people thinking and to think about issues through a public health lens. And currently, we've actually been testing this project with a couple different partners across Nashville. Anita is actually here today from planning, and we've been doing some testing with her. But actually, our first pilot started with the Juvenile Justice Center here in Nashville. They are working on a project to have a new campus. It's called the Nashville Youth Campus for Empowerment, or NICE. And the intention is to go from their current building that has existed for decades and has not quite been serving the needs of youth and families, especially the youth that are in detention at the moment, and trying to transform it into a space that really can provide the support that is needed to address some of those upstream issues that Julia was talking about when we're talking about not only youth violence and neglect and abuse issues that happen in the family setting, but all of the health implications that surround that, whether it is someone in the family employed, or is someone in the family experiencing a trauma and not getting the help that they need. And so we've gone through using this tool and trying to navigate the conversations that are needed to design a brand new campus that will take a few years to build out, but we have this time to really think intentionally about health in this context. And so there's kind of 3 pillars of the focus that we have within this tool, but the overarching theme is that we want to promote health, equity, and sustainability. And sustainability is one thing that I do want to mention because I think health and equity have really been talked about a lot, but we also want change that is not just for tomorrow, but that is for 10 years from now, and that we can actually be progressing and having our plans reflect what we hope society to look like and what that vision is for how we want to be. And so the 3 pillars that we've focused on is first having a real conversation of all of the ways that a project can impact health. So that connects to the health impact assessment that was discussed earlier. And part of it is, encouraging people to look at data and look at it through the lens of the social determinants, whether that be transportation or housing. And we also do talk about gentrification and segregation and discrimination and the whole range of issues that are connected to health. And the way that we pose our questions is not just, how are you hoping to change this? How are you hoping to improve in the space of providing health services? How are you hoping to improve access to housing? But also, what are the possible unintended impacts? And this has actually been, honestly, a challenge for us to get to in some of these conversations, because when you're planning a project and you're making a decision, you have this idea of, this is what we want it to look like. We don't often think about all of the things that might get us stuck down the way. And in order to have sustainable change, we need to be thinking about what might happen 5 years from now. What might happen if we present this to city council? What might happen if we have to displace this community and move it somewhere else? What are all of the health impacts that come out in that space that maybe we're not thinking about? And having an in-depth conversation about some of these issues is something that we're trying to toy with in terms of how deep do we go? Because we can go really deep, but also we understand that people, when they're making a decision, sometimes we need speed, sometimes we need efficiency, and figuring out when to pause and also where to prioritize our energy. The second pillar is really focusing on this community engagement that we've been talking about today as well. And so part of it is looking at cross-sector collaboration and asking questions related to who is represented at your table when you are engaging different sectors? Do you have representation from all of government? And when are you engaging them, and when is the right time to pull them into the conversation? And also, we're talking about community engagement and really seeing the community as a key stakeholder and understanding that there are also gaps in representation that exist in many conversations, whether that's you're having a town hall and only specific people show up and some people have the loudest voice, or whether or not you're inviting organizations that focus on disability issues, whether or not you're inviting a specific racial community that is going to be extensively impacted by this decision. And so making sure that those who are most impacted have the resources to contribute to the project, have the ideas and the expertise, are invited and are engaged deeply. And that's also one thing we've been trying to look at, is not just getting to the level of we're informing people about this project, but who needs to be leading the project, who needs to be a collaborator, who needs to be brought in to the decisions. And then there are also some people where maybe because of time constraints, like the conversation earlier in terms of getting people to come out to community meetings, there are difficulties there in understanding the nuance, but trying to get as much as of our community involved in the process so that down the line, and this is again related to that sustainability piece, 10 years down the line, the community isn't saying, this isn't what we asked for, this isn't what we needed, and instead can say, this is exactly what we asked for, and I'm glad my government listened. And the third component is talking about transparency, accountability, and review. And so really looking at how are we building in mechanisms throughout our decision making to look back at ourselves and figure out how we can do better. So that's the review part in terms of how are we evaluating what we are doing, how are we getting the information we need to make decisions that are educated and data informed, and also how are we building in checkpoints for ourselves so that when we get stuck or when the community needs information, we have a plan in that we can use. And so we've kind of compiled different types of tools. The three main things that we're focusing on the moment is a checklist just to kind of get an idea of what is going on, and asking simple questions. It's much shorter to fill out. It gives us an idea as the Health and All Policies team of what support might be needed. But then the real meat of our tool is assessments that are done in a facilitated process where there's a lot of dialogue between the decision makers for this project. And currently it's us, the public health department, but hopefully down the line, we can get people all over metro government and even in the private sector to be facilitating these conversations and to be able to ask the questions that need to be asked so that this health lens exists where it needs to be, where decisions are being made. And then the last part, we do debriefs. And so these are conversations after the assessment, once we've given them reports on kind of where they're at. We follow actually like the Bloom's taxonomy, which is a way of understanding learning and kind of having a transparent conversation of where we think the decision makers are in utilizing the health lens and learning how to apply their health lens and providing that feedback so that they can go further to address those upstream conditions or incorporate community needs or build in more accountability. And then in this debrief, we also get feedback, which that's what we're working on at the moment. And part of what I was asked to do as a panelist was to talk about our opportunities as well as our challenges. And so opportunities, we have really cool people working on this project. We have our epidemiology team working on it. We have our policy people working on it. We have our performance evaluation people working on this project. And it has been a learning process, and we provide each other with an endless amount of feedback, and we're still working on it. But the exciting thing is that this is something that we're hoping to adapt. The challenge is it's really hard to adapt a tool to meet the needs of what the decisions are in the community, whether that be just trying to understand all of the decisions going on in planning, which I'm still figuring that out, or to understand how decisions work even outside of government, or maybe at different levels of government, whether that's the state level, maybe it's Metro Council, maybe it's the mayor's office, or maybe it's within an individual department. And so trying to adapt this tool so that it's actually useful for people is something that we are working on, that we want feedback on, and hopefully we can work with the people in this room or the people that you know to try to test it out, to try to provide health feedback on decisions that are being made, and also help us really tailor this tool to work for Nashville's community and work for the health needs that exist here. So yeah, that's what we're working on.
Well, I'm excited to have learned about that, and look forward to learning a lot more. Thank you for all you're doing. I will now pass over to Meg Morgan with Root Nashville, which I'm also very excited to hear about this project and all the trees you're bringing us. Thank you.
Yes, thank you. Can y'all hear me okay? And I do have slides I would love to show, and maybe I'll give like a signal, or does the clicker work? I'll get rolling in any case. My name is Meg Morgan. Oh, wonderful. Yes, thank you. And I am the campaign manager for Root Nashville at the environmental nonprofit, the Cumberland River Compact. Might seem a little out of the box to have an environmental nonprofit here, but it really isn't, as we'll get into. So I'm grateful to Tracy and to Latrice for the invitation to be here. And also, Julia set things up for me very nicely by talking about climate change as our #1 public health threat issue that we are facing. So wanted to start with a little bit of context for this conversation about tree canopy and health. And that is that in Nashville as a city, it is a sad and sobering but very true fact that we are losing trees as a city. We're losing trees to development and to growth. It doesn't help when we have storms like tornadoes and derechos and floods, and by the way, we're only going to have more of those. We have an aging tree canopy overall. Trees live a long time, but not forever. And we also have an invasive insect that is going to kill all of our native ash trees, and that's about 5% of our canopy. So that's something that we should really, really care about, because trees give us so many different kinds of benefits. I'm just going to touch on some of the public health benefits for this audience, but there are so many benefits in addition to these public health benefits. But if you think back to, your middle school science days maybe, or elementary school, remember, of course, that trees provide clean air. And there are study after study that shows that the more trees you have, the greater canopy that you have in an area. The hospitalizations due to asthma decrease. So they're really important for that reason. That map of Davidson County in the bottom corner is called the urban heat island effect. And that is showing that areas with more impervious surfaces, which is a fancy way of saying concrete, are hotter than others. And as you all know, heat-related illnesses are really serious, especially in vulnerable populations. So that's something that trees really help with for our local temperatures. They're also critical for water quality. The map of squiggly lines is a map of our watershed, and those blue squiggly lines means healthy waterways. And it is absolutely interconnected and tied to how many trees are in that area. So the unhealthy waterways are where there are fewer trees and fewer canopy. And of course, we need clean water for many different reasons. It's also just really good to be around trees for our mental health. If you think about what it feels like to be in a park, or even what it feels like to sit underneath a tree, usually don't feel stressed in that kind of situation. Your blood pressure goes down, your heart rate goes down. There's lots of public health benefits associated to mental health and tree canopy. So before the fact that we are, losing trees as a city, and yet they're so important for public health and environmental health, and of course these things are interconnected, this is why the Root Nashville campaign exists. So this campaign launched in October of 2018, and it is structured as a public-private partnership in itself. So Root Nashville is not a standalone organization or entity. We describe it as a movement. It's something everybody can be a part of, but the leads of the campaign are the Cumberland River Compact, which is an environmental nonprofit, and Metro Nashville. So this is something that our government is behind as well. And we work with a bunch of different departments, but especially our Metro Water Services Department, because that's where our urban forestry hub is located in Metro. We have a very big goal of restoring canopy as a city and as a movement and a partnership by planting 500,000 trees in Nashville by 2050. And this is to restore what is being lost and get us back to what we need to have a healthy community. So we've got this big old number, 500,000 trees, we've got this timeline, but really the why of why we're doing all of this is to create neighborhoods that are healthier, that are more equitable, and that are more climate resilient for the future. So this is why we're doing it. This is why we plant trees, is to have a healthier community. And what does that mean? What does that look like? Does this look like an area that is ready for the future as it gets hotter, and as we have more extreme rainfall events that we're predicted to have in Middle Tennessee. Does this look like somewhere where kids would want to play outside? Does this look like somewhere you'd even want to go get your mail in the summertime? Is this somewhere where you'd be likely to go on a walk with your dog? As compared to a neighborhood that might look more like this one. Where would you rather live? What looks like a healthier neighborhood? What looks like somewhere that is more comfortable to be in the summertime? Somewhere that's ready to receive more extreme rain and have healthier air, all these other things. So this is a partnership and a movement, and fortunately what helps me sleep at night with this very big goal that we have is that nobody is in this alone. It's very much a partnership-driven effort. On the Root Nashville campaign website, you can see where all the newly planted trees have been added and who's planting them and what kinds of trees they are. We're at close to 26,000 trees since October of 2018, so we're on our way. We still have a long way to go. But no matter who plants trees or how, if it's in Nashville, those trees can count towards this movement and towards this goal. So from the very beginning of the campaign, it does have a very intentional health focus and perspective. And again, that's the why of why we're planting trees, is to have a healthy community. So from the very beginning, we had this intentional health perspective, and part of that is built into our structure. So the campaign has an advisory board, and the local nonprofit Nashville Health is the chair of our advisory board. We're also fortunate to have Metro Health representative on that board with Tracy Buck, thank you Tracy, and have partnered with our health department on several kinds of projects, including different grant opportunities. We've had public input sessions in partnership with Public Health Department and lots of other things, but it's really baked into our structure and what we do when we're planting trees. There's a lot of different partners in this effort. Again, that's what makes this goal possible, and all of these different partners have added and contributed towards this goal of, so far, almost 26,000 trees. I know our friends from Socket and General Services are here as well, so just want to highlight that, yes, it is led by the Cumberland River Compact and Metro, but there's a lot of different partners that are involved in this work. So we plant trees everywhere, but also really wanted to talk about our equity focus with the campaign, especially as that has been a really important kind of reoccurring theme of the conversation today. So we do plant all over Davidson County, but we do focus in these areas that we call impact areas, and that's because this is where the data shows trees can have the most impact and the most benefit. And I won't get into all the details of how we determined these impact areas, but several of those data points included: where are there higher rates of asthma? Where are the neighborhoods that are hotter? So there were quite a few public health kind of statistics and measurements that we looked at to see where do we need to focus our tree planting efforts. So the campaign is a public-private partnership, and that is also helpful because those are different types of land that we are planting trees on. There's public property and there's private property. I'll just kind of go through this really quickly to just mention that these opportunities are out there, and if you want to learn more about any of them, come see me or go to our website. But 94% of Nashville's land itself is actually privately owned. So the vast majority of the land is privately owned. So we realized pretty quickly in the campaign that we're going to need a strategy to get trees to private property. So we have a program called the Neighborhood Planting Captain Program, which is an entirely grassroots program where neighborhood leaders tell their neighbors, hey, free trees are available. We deliver it straight to your yard. Here's how you sign up. Shout out to a neighborhood planting captain that we have in the audience, Carson Cooper, who's recruiting her neighbors in South Nashville right now, getting more trees in her neighborhood. We also have strategies for getting trees to larger sites like places of worship, HOAs, apartments, things like that. We try to make it as easy as possible. The bulk of this work, it's a very small team, but with lots and lots of partners, and we really, really work so strongly and rely so heavily on community members to lead efforts within their own communities. We try to make it as easy as possible by providing the materials needed to do so. And again, won't get into the details of this particular program here, other to say, check it out if you're interested. Planting season hasn't started yet. We get kicked off in mid-October, plant trees all the way through the end of March. Now is the time to get your projects planned. And what does this say? Oh, just want to also make sure, give a proper shout out to our Metro partners because yes, that's a smaller, significantly smaller sliver of land, just 6% of the land, is publicly owned, but Metro is very committed to this partnership and goal, has planted about 30% of the trees so far in the campaign, and that's just on that smaller piece of property. So I know that many of you might be connected to, maybe your place of work is public property itself, so wanted to name drop a couple people within Metro if you were interested in getting trees planted at your place of work. If your place of work is a health department or somewhere that is managed by general services, you can reach out to Liz to get trees planted. Other types of public property like street trees, you can contact Rebecca or you can contact me and I'll get you to the right person. So would be remiss not to leave with a call to action, and that is to say that we are in the very fortunate and unusual position of being funded. We have what we need to plant 500,000 trees by 2050 as of quite recently. So really our biggest need is getting more people involved, getting more sites interested, more people advocating for tree planting, whether that's in your own yard, if you're fortunate enough to own a piece of property and have a front yard or backyard, or if you have any sway over any piece of land that you might attend or go to, if you go to a church, if you are connected to a school, if you frequent a local business. We tell people all the time that means, hey, guess what? You are a steward of the environment. You have sway over that land and what happens there, and you have influence in what you do. So join us. This is our group of neighborhood planting captains and other partners. You absolutely do not need to be a tree expert in any way to get involved and to do this. And it is for the reason of health is why we're trying to increase our canopy. So I'll leave my email up there, and that's our general kind of inbox as well. But I'll be around today if anyone would like to talk more, and happy to answer questions later.
Thank you so much. I can definitely relate to the benefits. I actually hike like every weekend for my mental health and well-being, but I appreciate learning about this, and you just got yourself at least one more volunteer, so thank you so much. And I can't help myself because I'm kind of corny, but I just learned a joke about trees, so I'm going to share it. But what is a tree's favorite beverage? Root beer. All right. Now we're going to kick it off to Director T. Gonzalez from the Louisville Metro Department of Public Health and Wellbeing, or Wellness, sorry.
Hi, good morning, good afternoon. I'm not sure exactly what time it is. My name is T. Gonzalez. I serve as the Director of the Center for Health Equity at the Louisville Metro Department of Public Health and Wellness. I'm glad to be here today. Here's some interesting projects and ideas kind of being batted around. Just a little bit of introduction about our health department. So the Center for Health Equity is kind of one of three major sections of our department. Around 5 years ago, we kind of made this transition. The center was originally established in 2006, but always kind of traditionally had a very small staff. So around 5 years ago, under the direction of our previous director, Dr. Sarah Moyer, started to make some realignment in our department so that now we kind of have policy component, our community engagement, our strategic partnership, a lot of our population health like data analysis, and our performance management components all under the Center for Health Equity, kind of working together to really transform our public health practice. And so that's how we're approaching things today. And I think when we're talking about health and all policies, it really, and as I think has been discussed here today in many ways, really rely upon those various skill sets around policy development and analysis and evaluation, along with the data components, the community engagement and strategic partnerships, all have to be working in tandem. So it's like kind of the benefit for us that all of those are housed within the Center for Health Equity. So our teams, our staff are, some of them may be different for them, but they get accustomed to kind of working more so in a kind of matrix environment and where they are kind of always collaborating with people and working significantly alongside people who may not necessarily be on their team per se, right? So we can't achieve any of this type of work without kind of having those skill sets really firmly established and then develop, and kind of having committing to capacity building within those skill sets for our public health staff. I think that one of the interesting things for me, I think in our practice, right? So in our vision to achieve health equity and improve the lives of all of our Louisville residents and visitors, the practice of doing that, when we're talking about health and all policies or trying to work towards health equity, for those in public health department, adopting a public health 3.0 model, we're focused on those social determinants of health, we're focused on strategic partnerships. The real challenge then, I think, becomes that we as public health practitioners, especially like located in local government, in a local health department, a lot of the issues that we're talking about, as have been discussed here today, so if we're talking about housing or transportation or education, fall outside of our jurisdiction as public health practitioners. So this is the real challenge, therefore emphasizing even more so our need to really focus on and build up those strategic partnerships, and also be, I think, in some ways, the leaders, which we are trying to be in Louisville Metro government, the leaders for how we are doing authentic community engagement in a way that is not only about, I think someone said, providing updates or informing our communities, right? But instead having them be the drivers of actually what type of policy initiative it is that we ought to be undertaking. So for us, some of that has looked like trying to establish a community advisory board, which is different than our Board of Health, right? So I appreciate the work of our Board of Health, and I think it is fair to say they are not representative of residents, the whole swath of residents of our community, and certainly not residents who may be experiencing the systems of power like racism and classism and all the others as the most heavily negatively impacted in our community. And so therefore we have to make other models, other ways of being able to have our residents be able to have more access to decision makers and more access to decision making. Right, so it's a work in progress that we must do this, and so I think that's an important component, and it's a practice, right? It's an evolving practice. I think somebody said, sometimes certain things that we try out may not work, but that's okay because we're trying to innovate our public health practice, and so we continue to do this, and we do it within the context of Louisville Metro government. You're doing it here within the context of Nashville. And those contexts, I think, may have some similarities, but they're also different. So then how do we then engage in where we may not necessarily, we may have a vested in public health interest in addressing certain issues that fall outside of our jurisdiction. And I think some of it is indicative of what's been described here today and some of the partnerships that you all have. Some of that is about transforming our inward practice. I kind of think of our practice as in, out, and with. So our inward practice has to change. That's about that building up that capacity for us to understand what are the needs in our community, and do we have people who are employed in our public health department who are able to address certain policy issues and learn about analysis and evaluation and do that type of work. So we have to focus inwardly and building up our own equity framework and skill sets in order to put that into practice. And then I think about the outward component, right? So how are we connecting then to our residents? How are we building up very strong strategic partnerships, especially when we talk about some others have talked about inside-outside strategies. Sometimes our strategic partners and our residents are able to speak in ways that we cannot necessarily do. And so we are relying on them in order to, quite frankly, from my perspective, to apply pressure to local government, which may not necessarily always, because of politics, be able to come in the same way from us as a public health department, right? So we need that component. And then I think about the with component, and this is a part for those of us who are in local health department or across city government. How are we working with our other agencies in order to build relationships, and as the public health practitioner, then start to hopefully try to have some influence with other agencies who more likely have jurisdiction over some of the issues that we're talking about. And some of this then, in Louisville, we have a strong mayor form of government, so we're in the executive branch. But so then how are we building a relationship with the Metro Council members, right? So some of that, even just this week, as we're looking at issues around how might we use our rental registries to talk a little bit more about the quality of housing, and then some of that, like if we can push it to really getting like a lead registry, right? Because we know that lead is a serious issue in our community, and we think probably the fullness of it not representative in the data that we have, right? So trying to push this. So how can we provide resources that we know about as public health practitioners to elected officials, right? So they can have a little bit more technical assistance to thinking about how some of this is, how some of these advancements and policy are happening across the country. And I think that's where we have to use our relationship and kind of advance these issues. So those are some of the things that we're talking about right now about this. How do we utilize our rental registry, maybe push towards how that might intersect with a lead registry in our community. Very early conversations about how to do that, but we think necessary. And trying to get, again, like I said, influence into areas where we may not be the only decision maker, right? Or the decision maker may fall totally outside of us, but how do we have influence there? We're having significant conversations in our community, I think many communities, talking about houselessness and the way that one of the ways in which that represents itself is certain encampments in our community, right? And what are the public health needs there? And also, I think as policies are made and policies are revised, how do we push ourselves in our inward practice to drive a different message instead of having others who think they know what the fullness of a public health message is, right? So we'll have many people say, hey, encampments, people living in camps is not good for human health. Well, we don't think that is the actual, the full story, right? Also displacing people from where they exist, right, where they are living right now, right, can have actually other detrimental effects, right? And there are certain benefits. I mean, we have a behavioral health equity team that's also part of our Center for Health Equity. And one of the things we're trying to communicate to other decision makers in Louisville Metro government and also to the Metro Council is, listen, a lot of folks who are in encampments may also be engaged in substance use, and they keep each other safe, right? Knowing who is here and in my community, I'm able to maybe administer Narcan if I need to, right? They're literally every day, not just, it's not just maybe if. We actually have people who are saving each other's lives in that way. And so to disrupt encampments is not just a clear picture of certainly to live in a camp is bad for human health. It's more complex than that. And we have to be able to speak to that as public health practitioners in raising some of the complexities. I'm listening to the story about the trees, and I'm thinking, our tree ordinance in Louisville got very political in ways that we were not anticipating. I mean, I think the city was not anticipating. But, it is true to say that managing trees that are on your property can be very expensive. And we had lots of people in our community who may be living in neighborhoods that are the exact neighborhoods that could benefit from a lot of influx of trees being planted, saying, hey, we can appreciate what you're trying to do, but we're not able to incur the expense of the maintenance of these trees. And that's a very real thing. Last year, unfortunately, I had a tree removed from my yard because I was really worried that I think maybe this may be hitting the foundation. It's certainly moving my sidewalk, right? So really didn't want to, but personally had to remove a tree, and I'm thinking, I know exactly what that bill cost for me to remove a tree, right? So, or to have it maintained, people to come out to, whatever. So all these equity issues are also very complex, and I think we have to be able to hold that complexity as public health practitioners where we're talking about human health and all the dynamics of equity. And that's about continuously building up our skill set and our practice as public health practitioners. Thank you.
Thank you so much. That example of like the complexity part really kind of shines light on, there's so many angles to consider, so thank you so much. Just a quick update. We're gonna end up skipping actually Q&A for the panel to try to keep on schedule and make sure we have enough time for the breakout sessions, which will follow directly after this. And so after we hear from Melody Gibson here in a moment, I just want to let you all know, if you go straight out and to the right, that's where you can pick up your lunch. And then if you could go directly across from that into the other conference room, that's where we'll organize the breakout sessions and have like a working lunch. Where we can all make some progress and collaborate together. But now, without further ado, I'll pass it off to Melody Gibson from the Civic Design Center, and I'm very excited to hear about your work helping our neighborhoods and our youth.
Great, thank you. Oh, clicker. All right, so like he mentioned, I'm Melody Gibson. I'm Education Director at the Civic Design Center, leading our 2 youth programs, Design Your Neighborhood and the Nashville Youth Design Team. At the Civic Design Center, our mission is to advocate for civic design visions and actionable change to improve quality of life for all. So we define civic design as community representation in how our cities and neighborhoods and communities are designed, planned, and built. At the foundation of the Civic Design Center, which was one of the organization's first major projects, was this widespread community engagement effort in order to create what we call the Plan of Nashville. And so it's a community-informed, long-term vision plan of design work to guide the city's growth and development. And out of the Plan of Nashville came the guiding principles for civic design that just provide like a framework and guidance that's specific to Nashville for how we should grow and develop. And one reason we felt like this was really important is because historically in Nashville, and of course, not just Nashville, across the country as well, urban planning practices have led to a lot of harm, specifically in communities of color. And so we felt like it was important to have guidelines to at least state this is how we do urban design for good. And so these principles cover a wide range of industries that we've been talking about today. We have principles about housing, transit, how to integrate health additions into a neighborhood, parks, the list goes on. And so, of course, those in and of themselves are separate industries. And so we see this more of like an ecosystem of how a community needs to be made up in order to be livable and equitable and a place where people can thrive. And so we see the Design Center, since the beginning, we've seen ourselves as a connector among all of these industries to try to create collaboration and understanding cross-sector, and also crossing over into the public realm. So how do we connect the public community members to the industries, to our municipalities, to all collaborate in order to have good design? I'm going to highlight a couple of our programs and then a project. So first, these are our 2 youth programs, the Design Your Neighborhood, which is It's a curriculum that's taught in metro middle schools that asks students to problem solve issues in their neighborhood that are impacting them, very hyper local. So problem solving issues related to walkability in their neighborhood and the lack of affordable housing available. And then we kind of consider that baseline knowledge for what we hope every youth will experience in their middle school education. And then we recruit from the middle school classes in order to have our Nashville Youth Design Team, which is a high school internship program. And the Nashville Youth Design Team, they focus a lot of their work on community research, specifically with youth, other youth. So they create tools for surveys and interviews and things like that, and they do outreach to youth all over the community, and then take that data and try and notice trends. And the data is specifically centered around, their framework is all centered around youth wellness, and so they've broken it down into factors such as recreation and social wellness, your intellectual wellness. And so they're asking other youth, how do spaces in your neighborhood support or not support these different areas of wellness? And then they have those categories and that data to go off of. Let's see, keep going in the interest of time here. There we go. Okay, one more program and then I'll get into a project. This is our Turbo program. It's called Tactical Urbanism Organizers. And so tactical urbanism just means a really fast, low-cost change to your environment that's meant to be temporary and experimental and inspire long-term change. So we have this program that takes ideas from community members and we ideate with them and get out and actually build or paint some type of change. And so the project that I'll highlight happened on Dickerson Pike, and we merged our youth design team and Turbo programs in order to do this project. And like I just mentioned, the youth design team bases all of their design work in data, and they were recognizing how much more youth their age want more walkable and accessible communities so they don't have to depend on adults to drive them to work and things like that, or school. And so they decided to look at that issue and then focus in on Dickerson Pike, where they noticed that there was a problem of pedestrian deaths, which it's not just Dickerson, but that was the one that they decided to focus in on. This is a picture of a really typical street where people are regularly walking through this on Dickerson because it's a pretty highly trafficked transit corridor where a lot of people in this community rely on public transit. To get to a stop, you have to walk through a ditch and you have to cross like a really fast or like huge 5-lane road. And so this is the area they focused on, specifically the intersection of Hart Lane and Dickerson. And they designed a tactical urbanism solution, which involved having so they kind of extended the shoulders there and painted a really brightly colored mural there, so it catches the eye of the drivers. It kind of notes that place as something special and gives more space to the pedestrian. Also, one of those crosswalks was not previously there to this, so they wanted to paint the crosswalk, and then NDOT came in and did it for them, which was exciting. And so there they are with their finished design. And I will note, just since we're talking about cross-collaboration, these were all of the partners involved in some way in making this happen. TDOT specifically, of course, had to give approval for something like this to happen on a state route. And this was the first tactical urbanism they had ever approved on a state route, was when the youth asked them if they could do it. They've said no to us adults plenty of times, but in this case, we consider this like a systems change, because now we have this method of tactical urbanism we can use in order to inspire and get the community involved and engaged about these issues around pedestrian safety. And I will say now TDOT has recently said that they're going to invest quite a bit of money into long-term permanent improvements on Dickerson. So a complete street that's going to have, safer sidewalks and bike lanes. And that was spurred by the youth design team's advocacy, along with Walk Bike Nashville, who did a lot of work around mobilizing that community and really advocating for safer streets there. So that is all. And
thank you so much. That's powerful, and thank you for reiterating the power of youth and for leading the charge. Thank you so much. And thank you to all the panelists and to all of you for attending. And we're going to head out to lunch and do our breakout sessions after a quick round of applause for everyone. All right.